In the 1980s, Dr. Paul Farmer introduced the idea of accompaniment to global health when he and his Haitian colleagues reimagined caregiving to be patient-led. Broadly, accompaniment means being there together for as long as it takes. Paul once said, true accompaniment does not privilege technical expertise above solidarity or compassion or a willingness to tackle what may seem to be insuperable challenges. It requires cooperation, openness, and teamwork. Accompaniment is an open-ended commitment to long-term partnership. It means walking with patients on their care journey until they are not just better, but whole. This guiding practice requires caregivers to have a moral responsibility to embrace patients' lived experience and to be present through ups and downs, struggles and fears. Built on empathy and respect, accompaniment is about being with rather than doing for. It is meant to be supportive, not supervisory. It flows between two people and lifts both up. The duties of accompaniment are broad, ranging from medical care and treatment to emotional well-being and social support. Today, this simple yet powerful framework extends beyond patient care and influences research and education. It requires continuous learning and an open heart. And ultimately, accompaniment is fueled by a common goal: to alleviate suffering. Accompaniment is a reminder that to care is to commit, to walk in solidarity with those we serve, and to be willing to address, as Paul reminds us, seemingly insuperable challenges. When we embrace the practice of accompaniment, we advance global health equity. We leave no one behind.
Please welcome Dr. Vikram Patel to the podium.
Good afternoon, everyone. What a buzz there was this afternoon. It felt like a congregation, and in fact, and indeed, it is a communion of people who have met again 1 year later since the first time we met to celebrate and remember a person we all love and miss so very much. My name is Vikram Patel, and I'm delighted to welcome you. I am the Paul Farmer Professor of Global Health and the chair of the Department of Global Health and Social Medicine, a position that Paul served in for more than a decade. On behalf of the 4 partner institutions, as the Harvard Global Health Institute, Partners in Health, the Division of Global Health Equity at the Brigham, and my own department, I welcome you all, those who are present here in person, and I know several thousand people who have joined virtually for this second edition of the Paul Farmer Symposium. As you can see on this word cloud, accompaniment in your own thinking can mean many different things. But it was one of Paul's most evocative ideas. In the wonderful video that we saw, we heard some of the ideas being expressed in reality there. To use his own words, to accompany someone is to go somewhere with him or her, to break bread together, to be present on a journey with a beginning and an end. I want to quote Arthur Kleinman, who wrote very beautifully a little while ago about Paul and his idea of accompaniment. I think Arthur might be here today, so he'll probably recognize his own words. There he is. Arthur wrote, Paul borrowed it, the idea of accompaniment that is, initially from liberation theology, and turned it into the guiding practice of clinical work among HIV/AIDS patients in Haiti, those suffering from multi-drug resistant tuberculosis in Peru, and terrified Ebola patients in West Africa. He theorized that a form of care centered on caregivers' responsibility to their patients that emphasized their ongoing practical and moral presence and a commitment to keep treating patients over the course of their illness. The moral responsibility of the healer is to step inside patients' experiences, spoken like a true anthropologist, and accompany them through the worst moments with empathy and expertise, compassion and care for as long as it takes. The idea of accompaniment, although it arose in the crucible of chronic infectious diseases, actually has very great relevance to many other human health conditions that are associated with chronicity. And of course, mental health problems, the area that I have devoted my life to, is no exception. The work on mental health equity has equally been inspired by similar movements that have championed the idea of accompaniment. My own work arose in the crucible of India, where healthcare pioneers developed the strategy of community health workers, which is so central to Paul's own idea in the 1950s. And they evoked a long-standing tradition in South Asia of community engagement and empowerment. At that time, the primary focus of this community engagement was to address the large unmet health needs for mothers and their newborn babies. Indeed, back then, South Asia was contributing more maternal and infant deaths than any other part of the world. India alone, in fact, had the highest maternal and infant mortality rates in the world. Through a systematic demonstration of how such community-based providers, with the support of other community sectors, could not only deliver essential care to mothers during childbirth and their newborn infants who were experiencing sepsis, but they also demonstrated how dramatically this approach could reduce maternal and infant mortality. This approach is not only now enshrined in India's national health policy, which is exemplified by a million-strong woman-led workforce that has now led to dramatic reductions in maternal and newborn mortality, but is also embraced by many countries around the world. In fact, it's not surprising that in 2022, the World Health Organization awarded India's ASHA, that's the name of the frontline worker that is now part of the National Health Mission, its most prestigious Global Health Leaders Award. This recognition was given an appreciation of the vital role that ASHAs played in connecting communities with the healthcare system, especially during the COVID-19 pandemic, where they played a crucial part in health education, disease prevention, and ensuring that healthcare delivery occurs at the grassroots level. Following a very similar playbook, global mental health practitioners and scholars around the world have repeatedly shown how community engagement, empowerment, and involvement of frontline workers are highly effective in enhancing access to psychosocial interventions. And mind you, these are health conditions for which the vast majority of sufferers, a very recent survey showed that more than 95%, for example, of people in sub-Saharan Africa who live with a mental health condition have received no care at all. At the heart of this strategy is the notion of accompaniment to recovery, crucially important for mental health conditions, which can often be enduring, long-standing conditions. This substantial body of scholarship has today led to the mantra of diversifying the workforce. I'm sure many of you are familiar with that mantra, a mantra which is today not only embraced by governments around the world, but very importantly, back here in the US, where mental health equity remains a very long-awaited goal, and we're very, very far away from it. As you've seen from this word cloud, accompaniment as an idea, of course, extends well beyond clinical care. Indeed, for Paul, and again, I quote Arthur, it was not just a method, but it exemplified his life. The agenda for the program today, which has been marvelously brought together by representatives of all the 4 hosting institutions, demonstrate the breathtaking diversity of the idea of accompaniment. I'll just briefly introduce each panel and then invite the first panel to join, to come up on the stage. The first panel will be moderated by Dr. Joya Mukherjee, I think whose voice we heard in the video. Yeah. This panel will focus on accompaniment in clinical care, and panelists will refer to a variety of issues related to accompaniment of patients, clinicians, residents, government partners, and institutions in the practice of global health delivery. Following on, the second panel will focus on the idea of accompaniment in practice in teaching and research. And this will be moderated by Dr. Dan Palazuelos. Panelists here will refer to the accompaniment of students, researchers, and general audiences within the spaces of laboratories, the academy, and the larger world. After a brief break, we will hear a video message from the WHO Director General, Dr. Tedros, and then our event will conclude with a keynote address by Dr. Jim O'Connell, President of Boston Healthcare for the Homeless, who will discuss accompaniment in the context of his work. And I'm just delighted we have Dr. O'Connell here because it's a reminder to us that health equity is a very important goal in our own neighborhood, right around where we live. We don't have to travel all that far from this institution in order to encounter people who are underserved. He will talk about his work with the unhoused in Boston and the influence that Paul had on his life and his work. So once again, thank you all for joining us today. We have an incredible program lined up for you and for me, and I'm going to invite Joya and the first panel, please join us on stage.
Vicki, where is Ingrid? There she is. And Brian, wonderful. Okay, thank you, Vikram, and thank you all for being here and having this wonderful second annual Paul Farmer Symposium on Global Health. How fortunate we are to be in this beautiful garden today of friends and family, students, scientists, activists, clinicians. We were all planted here, cultivated, nurtured, with lots of sun and a little bit of rain by our chief gardener, Dr. Paul Farmer. In this role, he accompanied all of us. Today, we are going to talk about accompaniment in the clinical space and Paul's work and example, which has forever connected accompaniment with the provision of care in the pursuit of global health equity. Paul explains it is an elastic term. It means I will go with you on your journey and share your fate for a while, not just a little while. And all of these folks here have been doing this for not just a little while. Growing a garden, tending to the sick, raising a family, changing health systems, these are not quick fixes, but require long-term proximate care, attention, and indeed accompaniment. Among Paul's many professional roles, he was first a clinician. In this panel, we will hear from 4 FOPs, friends of Paul, about how their accompaniment of patients, of health providers, of governments has improved clinical care and has brought about, in many cases, a much, much more significant health equity. Next to me is Vicki Reed. She is the executive director of PIH in Sierra Leone. Next to her is Dr. Melino Ndezigie, who is the executive director of PIH in Lesotho. And I have to shout out one of the first graduates of the Masters in Global Health Delivery here in the Department of Global Health and Social Medicine. The pioneer class, Dr. Brian Remillard, who's the former section chief of nephrology at the Dartmouth Hitchcock Medical Center and an associate professor at Dartmouth, and Dr. Ingrid Katz, who is a director at PEPFAR, the President's Emergency Plan for AIDS Relief, a program that Paul was so proud of being part of. And she is also an associate professor at the Brigham and Women's Hospital. So we'll start with you, Vicki. Maybe you can just reflect a little bit on accompaniment in your clinical practice.
Good morning, good afternoon, everybody. I'm Vicki Reed, Director of Sierra Leone PIH. I think for all of our work at Partners in Health, no different. Sierra Leone is no different. Accompaniment is really at the heart of what we do every single day. In addition to accompanying patients, which we're known for mostly, we also accompany the government of the country to help strengthen the health system. We accompany our partners. But I think one of the things that I am most grateful for is the opportunity to be able to accompany nurses. I myself, I'm a registered nurse. I'm very, very proud of that. And in a and in our context where, the education of nurses is pretty challenging, there's not a lot of good quality education for nursing. I think I was almost had a culture shock when I returned to Sierra Leone, which is my home, to work with Partners in Health. And as a director of nursing, I think my job was not to just go sit in an office and, do day-to-day work. I mean, I think after the first day showing up in a skirt and blouse and some flat shoes, I quickly changed to wearing scrubs to show up to work every day because my work really involved being with the nurses at the bedside, caring for patients. In fact, now, even in this role, that's probably one of the things I miss the most. When all the work is pretty overwhelming, I always say, I wish I could go back to, just putting on some scrubs and going back to my comfort zone. The nurses in Sierra Leone are probably one of the most hardworking healthcare workers across the board. And, the opportunities are not there for them. I studied in the US. I had access to all of the great education, all of the tools needed to work as a registered nurse for me to be able to deliver, care at the best, one of the best facilities, the Grady Hospital. I mean, the Neuroscience Center. I mean, the exposure was there. There was nothing I lacked. So I was able to provide that care for the patients. But also one of the things I realized is that the mentorship that was provided to me after I finished my, my education was also quite valuable. And in a place where, that accompaniment is not there for the nurses to be able to provide that care directly at the bedside, it was pretty challenging. I think just to validate that this was such a valuable experience for the nurses, I could remember when COVID started in Sierra Leone around March or so of 2020. I'd just been in Sierra Leone now for approximately 1 year. I had a family. The US, of course, was being ravaged by COVID. And, we received the word back from the cross sites that, all international staff, make preparations to go back home to your, back to the US, even though Sierra Leone is home, make preparations to go back home. And, just watching the nurses that I've been working with for the past year and how much they'd come to depend on my support. I mean, I really couldn't look them in the eye and decide to leave. And so for me, I think that's probably, I hope I don't get emotional, that's probably one of the most touching experiences because they've been used to seeing people come and go. Everyone would come with their own expertise and leave. And, to have someone who is someone from their home, someone they had placed their trust in me, we had worked together, we had been in the trenches, we had gone through a lot of different challenges that we see every day at the sites. And for them to be able to, look me in the eye, or I could look them in the eye and reassure them that I wasn't going anywhere, I was going to be able to stay. For me, I think that's part of what it means to really accompaniment. I think you highlighted that quite adequately when you mentioned that it's not to stay for a short time, it's to stay for the long run. So for me, that's probably one of the things I'm most grateful for.
Thank you. Thank you so much, Vicki. Just to highlight, as you said, Sierra Leone is your home, but you were at the time, your family was in the United States and you made that decision to stay and accompany your colleagues, which is so amazing. Dr. Ndezigye, you had a very long friendship with Dr. Farmer. And maybe you can talk about, again, that length. What was that arc like for you of accompaniment from Paul and what you learned to deliver in terms of that accompaniment?
Thank you. Thank you so much, Joya. I have a lot to share with you about how Paul has trained me and mentored me on the accompaniment, real accompaniment. I'm Merino Ndaizigie. I am originally from Burundi. I'm a global health physician. I grew up in a rural village with no access to healthcare. I lost my father at a very young age when I was a teenager. And my mom worked hard to make sure that I continued school. And she always told me that she wants to see me with great achievements in life. In 1995, I was in a boarding school and I got very sick. And at that time, my country was going through a severe war. And I spent almost a month in a small clinic nearby my school. They couldn't tell me what was wrong with me. They just told me that I need to be referred to a specialist in the capital city. It was not easy to be, to travel to town because of the war. Then a friend of mine, a friend of our family, came to pick me and took me to the hospital in town, where a specialist told me that I had a life-threatening condition, and if I delayed, I could die. Since then, I developed passion about medicine, and I wanted to become a doctor who would provide healthcare to rural, underserved communities. In 2007, when I completed medical school, I happened to meet Dr. Paul Farmer. He came to our university to give a presentation. He talked about PH work in Haiti, in Rwanda. He talked about social determinants of disease, and he also talked about accompaniment. I felt really inspired by his presentation, and after the presentation, me and my colleagues approached him. We started to discuss and ask him questions, and he asked me and my colleagues to go visit one of the hospitals where we did rotations. We went there, and it was late in the evening. We started to see patients. We did a round, and I was really touched when I saw how Paul approached, the patients. He introduced himself. He asked them questions. He took time to examine them. He asked them not only questions related to their health, but also their social problems. And we did the round until 11 p.m. And I felt like this man is exceptional. He cannot even take a rest. You can imagine someone who traveled from the US to Burundi with jet lag, but he kept seeing patients, and we kept going on and on and on. And some of those patients have spent a long time in the hospital because they have not managed to pay their medical bills. Some of them didn't have food, and some of them, ended up contracting other diseases. And I kept telling him that the situation is the same in most of the hospitals in the country. And he looked at me and said, Merino, we will end this situation. And I felt like this man is so optimistic. This situation has been going on for so long. So I couldn't, see where that hope come from. So later in 2008, I joined Village Health Works. It's an organization that was founded in the spirit of PH. And Paul used to come and spend time with us. We saw patients, a lot of patients together. He mentored me how to be a good clinician and provide care beyond just medical prescriptions. Just to come back a little bit, when we were at the hostel doing a tour, the next day Paul called me and told me that, asked me questions about how the patients he saw the last evening, how they were feeling. And I was impressed. He remembered all the names and their conditions. I felt like this man has a special brain. So in 2014, I joined Partners in Health in Lesotho after completing my master's degree here at Harvard. And we were providing primary health care in the rural hard-to-reach areas, but also accompanied the government to improve health system. And, Lesotho had a lot of issues. Besides providing direct care for, primary health care patients and MDR-TB patients, we were taking care of orphans. And one of the orphans, Memankupane, who is actually now our OVC program assistant, lost her parents because of TB at the age of 3. PIH accompanied her, with all the needs. We got, we paid for school fees. We pay for housing, and we help her to really go through the hard time of her life. And now she's our orphans and vulnerable children program assistant, which is really great. It's always great to see like people who went through this hardship, now taking the lead to provide services. And I have been thinking, how best can we make sure that there are no more people who are like Mankupane who lose their parents at a young age. And I led different initiatives to improve the situation, and especially on addressing high burden of TB. By the way, Lesotho is the highest TB incidence in the world. And me and my team, we led introduction of decentralization of molecular testing at the health center level with establishment of mini laboratories equipped with gene expert machines. We also led introduction of use of artificial intelligence at the primary health care level and teleradiology. And recently, we also, I led development of a new system called TB Hunter system that is combining new screening methods, not only focusing on symptoms, but also adding epidemiologic risk factors and point of care testing using artificial intelligence and geographic information system, GIS. After introduction of those innovative technologies in rural hard-to-reach areas in the most underserved communities, we have seen a huge increase in TB case finding. As I'm speaking now, our case finding is 93% compared to the UHC target. As we are celebrating Paul's life and legacy today, I really feel honored to share with you how Paul has inspired me and transformed my career and made me a health professional who cares and a leader who I am. I will always and forever cherish my time with Paul. Thank you.
Thank you so much, Nolino. Dr. Remillard, we'll go to you. I think what we heard from Melino's story, of course, is the influence one can have when you start working with somebody just out of school, just out of medical school, and you stay with them. And you have provided a wonderful example. I think we first met after the Haitian earthquake. And as a nephrologist, maybe we'll need dialysis. There might be some crush injuries. And you got on a plane and came to Haiti and you left your heart there. So, Brian.
Thanks, Joya. Yeah, so maybe one thing I think one of the goals of today, I think, is to have everybody become accompagnateurs in their life. And so for me, what happened was I did exactly that after the 2010 earthquake. I had two criteria. I spoke French and I had technical expertise. And we were fortunate enough to have Jim Kim as the president of Dartmouth, and he organized this Dartmouth response. And a few days later, I found myself on a private jet landing in Port-au-Prince. And I thought I was going there to do a very technical job for a patient who had crush injuries in Hinch, a small town on the Central Plateau. And we did this successfully. And then the next day, the trauma teams left. And I was there with a very talented nurse, Ann Morozic. And I started to look around, and there were wards of patients. And I wondered, these were not patients from the earthquake. These were the everyday patients who arrived at Hinch. And I thought, well, who's caring for them? And I couldn't quite figure it out. And then they said, well, it's the social service residents. And it turns out in Haiti, after you spend 6 years in school, you spend 1 year giving time back to the government to be a social service resident. So I met some of them and I said, well, where's your attending? And things were in disarray, so they had no attending. So I said, well, I'm your attending. Let's go see these patients. And so we started to round on every patient, and there were no charts. So we kept lists of what they had and what we were trying to fix. And it was like a transformation for me. I just felt this warmth. And so one of the things I'd like to express is that you don't have to have an expertise in global health. You just have to follow your heart to be an accompagnateur. And 5 or 6 days later, I had to go back to the States, but I had a big expertise in telemedicine. And so I remained connected with those residents and did some teaching for a couple of years. And then in 2012, of course, Partners in Health and Zami Lasante built this wonderful medical center at Mirabelais. And there was a physician who heard I had done a talk in France, and he heard his name was Philippe Cleofat. And he called me and he said, I'm going to go back to Haiti. I said, what are you doing? He said, I'm the chief of medicine at Mirabelais. So we started to work together. And, you know, when I brought the dialysis machine, I worried that this is incredible technology. Is this the right thing to do? But then Paul taught me a lesson, which is that we're socialized for scarcity and that there is enough resources to go around if we decide that's what we need to do. And people were so happy to be able to save patients who would otherwise die from transient kidney failure. And so Philippe and I worked on this. We also came up with the goal of doing transplantation, which Paul absolutely loved, because the teams, I'm quite sure that if it weren't for the recent turn of events, we could be doing transplantation at HUM. We manage patients with multi-drug resistant TB. We manage complex HIV patients. Transplant is easier than that. So in any event, and then the other thing that we started to do was Philippe and I would talk about which residents had certain goals in their career. And I had some small funds and I would fly them to Dartmouth and they would come and spend time in the nephrology unit, in the cardiac unit, in the ultrasound unit, and learn skills. And one of the things that was wonderful was I never called a department head or a department where people weren't incredibly enthusiastic about receiving the Haitian residents. So over the years, I had about 16 or 17 residents come to the house. They stayed in my two boys' rooms who had left the house. You know, so they were in with the soccer trophies and all this stuff, and it was about the clinical thing. So they learned incredible skills for ultrasound, etc. But then it also was cultural. Every night we'd cook together. Every night we'd have a meal together. We watched movies together. We read books together. We went snowshoeing together, which was a unique experience for Haitians. And you know, over the course of those 7 or 8 years, they ended up in junior leadership positions, and it really created a network. And I learned that they all would go back and teach their skill to the other residents. So my Haitian residents can run a dialysis machine by themselves. They can do cardiac ultrasound. So for about 2 years, when Philippe had to be away, I was the virtual attending by WhatsApp. And they would call me, and they could provide an incredible detail of case because they'd show me the cardiac echo, they'd show me the abdominal echo, they would tell me about the case, more information than I ever would get from a Dartmouth resident when I get called from the emergency room. So, you know, that was really amazing. I think more recently, I think in 2021, I was in August, you know, the second earthquake occurred, and I was on the beach with my wife actually on Cape Cod, and I texted Paul and said, I've checked with Verily, who's was running the program, and I said, he said we could handle up to 40 patients with crush injuries, and we have all the, you know, the technical expertise now. I said, isn't that a wonderful progression from when I went? And he said, Paul sent, I think, what he used to call a corrective. He said, well, I said, I don't think I need to be there because they have the expertise. And he said, well, you should be there to, he didn't say accompany them, but to support them. And the next day I flew down and was with those residents, and it was the right thing to do. You know, more recently, I would say, you know, there has been a lot of turmoil in Haiti, and that's been very hard. And there is an incredible amount of brain drain, and all of the residents that I know have struggled with that. Their families have had troubles, and they've had to leave. And now I find myself accompanying them in their journey to find a way forward, given the difficulties in Haiti. They all are incredibly connected and want to go back to Haiti, want to use their expertise, but I think it's going to take some time to do that. One striking thing for me was after there was an incident at the hospital, I got a call from one of the residents who I know very well and said, can my wife and son come and stay with you? Because they had been in the line of fire. And for me, this was an incredible level of trust, and really, they came to the house and stayed with my wife and I for a month or so. Interestingly, I learned what it's like to have a 2-year-old in the house, and it turns out that no is the same in Creole, French, and English. So basically, you know, I think at this stage, yeah, my hope is that we can. I see the residents every week. So every week I teach on Tuesday nights. Tonight's an exception, for an hour. So I see all the young residents. About 6 weeks ago, I turned on the Zoom, and there were 8 young faces, brand new residents who had just started at HUM in the internal medicine residency program. And I think one of the other things Paul taught me was you can't despair on behalf of others. And so if these 8 young people want to use the knowledge to continue to help the poorest of the poor in Haiti, I'm there every night for them, and that's what we need to keep doing.
Thank you, Brian. I think that idea of how audacious Paul was in his ideas of accompaniment, to change a training program, to transfer this amazing technology of dialysis. Nothing is summed up more than in the President's emergency plan for AIDS relief. Paul could accompany everyone, including President George W. Bush, who really was moved, I think, by many of the stories from Haiti and elsewhere. And Ingrid, who was Paul's long-term friend and student, is now one of the leaders of that program. And so she's going to talk about accompanying governments, but also the young people in country who are trying to understand how their programs are working. Ingrid.
Thank you so much, Joya. And really, I'm so honored to be here. Thank you to Dr. Ivers for suggesting I join this incredible panel of people who are so dedicated. I see Paul in all of you, and probably many of you in this room. And it's such a treat to get to be here. You know, I think back to when I first met Paul, and I was thinking about the story you were sharing. It was actually before I started medical school. There was kind of a a mosh pit of young people around him. He was giving a talk, I think it was actually over at Harvard College. And I thought, who is this person? You know, he has people drawn to him. He had this way of building the bridge. I kind of call it the connective tissue that he builds with people at every level. And I personally felt so deeply inspired. I think one of the kind of incredible tragedies, but also gifts of losing Paul was seeing how many of us thought we were his best friend. I was like, aren't I his best friend?
And we were.
And we all were. We were all saying, wait, isn't he my best friend? And so I think back to when I first saw him, you know, he was obviously an attending at the Brigham, and he taught us that we really could hold these ideals that we were taught in medical school, how to be the ultimate caregivers, and that it's bi-directional, that the care is exchanged. And there were so many patients who taught me that. And I think one of the challenges of practicing medicine here in the US is often people can feel demoralized. It's a corporate entity, and often people feel like they don't have a voice in that. And I feel so fortunate that I've been able to cross boundaries and barriers and oceans to get to be in other places where there's actually a bit more fluidity. And it wasn't something I had anticipated, but the more that I experienced that, the more I saw myself almost as an outsider being able to peer in a unique way. When you're part of a system, sometimes it feels almost harder to make that change. But when you're an outsider, actually, it can be a really unique gift if you can do it in partnership with the people who are there. And I think that's one of the most critically important things. And I think Partners in Health and the people who created that, Jim and Ophelia with Paul, really had that vision. This was not about them. It wasn't about the NGO. It wasn't about the Brigham or Harvard. It was about the people they were there to serve. And then they would do it in partnership together. And so fast forward many years, you know, I started my work in terms of my research in Soweto in South Africa over 15 years ago. And part of what I came to see there, as in my lens as a clinician, but also a researcher, was that PEPFAR, the President's Emergency Plan for AIDS Relief, which was this tremendous program, which was started in 2003, had embedded in this clinic in Soweto at the Baragwanath Hospital, which is the largest hospital in the world. And you could see that people there were working so fast to rectify the wrongs that had been made. We had seen, I'm old enough, I went to the AIDS conference in Vancouver in 1996 as a young 20-something-year-old, where they announced protease inhibitors. Protease inhibitors are a class of drugs that were used as part of the cocktail to allow people living with HIV to not have a terminal illness anymore. And I remember this huge room of, you know, however many people, tens of thousands of people on their feet when they heard this. And I thought, even now, I get goosebumps. I think this is what I want to be part of. I want to be part of this change. And in that moment, I remember there was a minister of health from Africa who stood up and said, "Don't forget about us." And boy, was she right. Because exactly what happened in 1996, which repeated itself during COVID, was this huge divide that the US and Europe and other countries that could afford it got life-saving treatment for people living with HIV, and countries who could not, did not. And so it wasn't until 2003 when PEPFAR was started. And again, I credit so much of that to Paul and others who were advocating, many names well known now, like Tony Fauci, to push for this. But it also took President Bush to really see the potential here, that this would be monumental. And the rumor is, I wasn't in the room, instead of working in the M's, the millions, we were going to now work in the B's, the billions. And let me say that has come true. PEPFAR is the largest global health program ever created in the US government. It's pretty amazing. Right now, we have over 20 million people on treatment globally, which is, yeah. And I'm looking at Jim. He allowed my wife and I to spend a month with him when he was at the WHO. And at the time, he was proposing getting 3 million people on treatment by 2005, which was audacious to get that many people on treatment because no one was on treatment at that point. And to then turn it full circle, to have 20 million people. We have over 25 million lives saved because we also averted the transmission of HIV to newborns. And so when you step into a program like this, and I still feel like a neophyte, I've only been there a year and a half. I still can't quite believe I'm there. And I feel like it's such a precious moment where we have Ambassador Nkengasong, who is from Cameroon and really centers us on the continent and shares with us the way that we can accompany countries and governments and academics in these countries. It turns all of this on its head. And I was a skeptic, I'm not gonna lie. Large programs coming out of the global north made me feel a little queasy because I really felt like we needed to be more centered in the places where we were there to serve. But I have seen the impact of this investment, and it is monumental, from systems that have been developed to a healthcare workforce that has been so incredibly well trained, to all the investments that have been made across the board in every system that you can imagine that dovetails into HIV. And so I do feel deeply optimistic that we can do this together if we stay in partnership, that we work with the governments that we're here to serve. And we are at a unique moment right now in PEPFAR where we really are centering this idea of sustainability. And so what that looks like is really, and I was just in Cameroon and then in South Africa, and a lot of it is really ensuring that we are supporting the governments who are there, that they are leading this response and we are in partnership with them and helping them build the bridges they need to not only address the HIV response, but ultimately care for all the people who live in their country.
Thank you so much, Ingrid. So I think that's the end of our panel. I had hoped we would have time to go back, but those are such amazing and compelling stories. So I want to thank all of you for your accompaniment of governments, of trainees, of health centers, nurses, patients, really all levels of the care cascade. Really a privilege to talk with you. Thank you.
Please welcome Dr. Louise Ivers to the podium.
Hi, everyone. I'm Louise Ivers. I've been working now with Partners in Health, Amis La Santé in Haiti for 21 years. It's been a gift of my life. I'm a professor at Harvard Medical School. I'm the director of the Harvard Global Health Institute and a Center for Global Health at Mass General Hospital. I wanted to give a very, very brief reflection on this amazing panel. I'm going to start with reading something that Paul said at the Tanner Lectures at the University of Utah in 2005. The view of many of my academic colleagues seems to be that good scholarship and activism don't mix. The view of many of my human rights colleagues seems to be that social and economic rights, those violated in the settings of poverty and disease, are pie in the sky. We're having a hard enough time, I'm scolded by my friends in large human rights organizations, getting civil and political rights respected. The view of many in both sectors seems to be that if such rights are to be promoted, then the victims themselves should be empowered to start their own social movements. And yet it is not possible to argue that those gathered in central Haiti need to form a movement to promote human rights. They already have. The missing movement is the one that would occur among the privileged. It would be the one based on solidarity and empathy. Now, what Dr. Mukherjee did so ably, as she always does, and has done her whole career, is to call others forward into the movement of solidarity and empathy. And I think what this panel has shown us is a deeper understanding of what accompaniment is and how that movement can be brought forward. As Vicky reminded us, it's about staying. As Melino reminded us, it's about optimism. As Brian taught us, it's also when the technical becomes also following your heart. And as Ingrid reminded us, it's about exchange. Care is an exchange. It's bidirectional. And I think our panel has really highlighted that audacious plans can really come together through accompaniment. And I thank them very much for that. My job now is to introduce our next panel. And so I'm delighted to introduce Dr. Dan Palazuelos, who's going to moderate the panel about accompaniment in teaching and research. Dr. Palazuelos is a friend, and just like inspired by Dr. Paul Farmer, he has many jobs and wears many hats. He's a community health implementer educator, an assistant professor at Harvard Medical School, assistant director of the Hyatt Global Health Equity Residency Program at Brigham and Women's Hospital, director of community health systems at Partners in Health. He also has a role at Harvard Medical School in community education. He worked for over 2 decades to launch Compañeros en Salud, I hope I said that okay, Mexico, the Financing Alliance for Health, and Community Health Impact Coalition. During COVID-19, he served as the technical lead for the PIH US Public Health Accompaniment Units supporting migrant workers in Florida. And he's currently working with the Office for Community-Centered Medical Education at Harvard Medical School to support Boston-based community organizations and the students that are looking to partner with them. In all of his many roles, his unified goal is to assure that clinicians are trained to understand the community perspective. Our healthcare system strengthening efforts are aligned to the real needs of people living in the poorest and most difficult circumstances. I'll turn it over to Dr. Palazuelos and the rest of the panel. Thank you.
Thank you so much. Wonderful to see everybody here. So we have a wonderful panel here to continue the conversation about how accompaniment can inform and guide our research and pedagogic efforts. And I have the opportunity to introduce my colleagues here, Steve Reifenberg, Carol Mitnick, and Sachit Balsari. And I'm gonna say a couple of stories to introduce them. One thing I wanna say to frame this a little bit is that, when I had the opportunity to write about accompaniment with Paul and Joya for a Lancet Perspective piece on how accompaniment, the values of accompaniment could guide our community health efforts, we went back and forth with the language to use. And we came to this. Accompaniment is both a philosophical stance and a rubric for programmatic design. So it was Paul's idea to use the word rubric. And when I heard it, I thought, wow, that really pairs beautifully with the idea of a stance. A stance tells you where to start, a rubric tells you where to go. And isn't that comforting in these times? Knowing where to plant your feet, how to be grounded and unshakable, while also realizing that movement forward is possible, if not imperative, and that such progress can have structure and take form in familiar, if not proven ways. So the question that we're going to be tackling here is, in your experience, and perhaps what you learned from interacting with Paul and his works, what would you share with the audience as a key lesson for how the values of accompaniment can guide our research and teaching efforts? And in the spirit of Paul's tendency to build families and not just teams, I'm going to introduce them with some personal reflections on our many years or many great experiences. And so I'll start first with Carol Mitnick. So I first met Carol Mitnick when I was a resident at the Doris and Howard Hyatt Global Health Equity Residency at Brigham and Women's Hospital at Harvard Medical School, or Paul's residency. She was a researcher at Harvard doing tuberculosis, TB, and TB work in Peru. And as part of my first GHE rotation, Global Health Equity, I was able to go to a conference in Lima and see her present. And here I was watching this, and I thought, wow, she is so strong and steadfast and smart and unflappable. And it is that unflappability, of course, that has led her to become a full professor at Harvard. But also in Peru, it has meant that she has worked very closely with the TB team to help construct one of the most powerful institutions for advancing the knowledge that we have on how to treat tuberculosis. Just this last summer, Joe Radigan and I, who you'll hear from in a bit, took the 19th class of Paul's residency, the GHE residents, to Peru, and we had a chance to go to the labs and to see the research, and they were like, of course, yeah, this makes perfect sense. Those who are closest to the pain should be closest to the power. But what we know is that it took so much careful partnership throughout the years to build that from people like Carol, but especially Carol Mitnick. So with that, Carol, and I'll go and give personal reflections on each one before they speak, but Carol, I'd love to pass the mic to you.
Thanks so much, Dan. That's quite an introduction. I guess I was just going to also start with a personal reflection, and in my own first exposure really to research accompaniment was in the form of Paul's mentorship. And I met Paul thanks to my colleague Mercedes Becerra, who I think is somewhere in the audience, in 1995, when I was despairing about the disconnect between my doctoral program at a nearby institution, I'll say, and the reality of the suffering that I had seen after my first year of graduate school when I spent the summer in the Gambia. And that the complete disconnect was something that wasn't bridged in my courses. And I did not think that I could actually finish a doctoral program that didn't help me with that connection. And it was really only thanks to Paul's ability to help me see how to use research as a tool for solidarity and how to accompany in research that made it possible for me to finish and continue and have the privilege of working with colleagues at Socios and elsewhere around the world for so many years. So with that, I just want to think a little bit, I guess, about the frame, and I'm going to paraphrase the Merriam-Webster definition of research, and it is studious or systematic inquiry or examination, especially investigation or experimentation, aimed at the discovery and interpretation of facts or their revision and practical application. And then we've heard definitions of accompaniment in the opening video narrated by Joya, and also in her comments and in Vikram's comments. And the part I just want to highlight is the part about going with you and supporting you on your journey wherever it leads, and sharing your fate for a while. And by a while, Paul said, I don't mean a little while. Accompaniment is about sticking with a task until it's deemed completed, not by the accompagnateur, but by the person being accompanied. And that, to me, that longevity is really key to research accompaniment. But in thinking about those two definitions, it really led me to the question of how did Paul and how does his legacy help us to connect those seemingly orthogonal concepts, that of investigation and accompaniment. And I would argue that, like most lines of inquiry with Paul, the answer is at the same time dizzyingly complex and maddeningly simple. And the complexity arises from the range of disciplines and methods and levels and dimensions that go into accompaniment, while the simplicity lies in the purity of principle for Paul. And I'm just going to touch on each of these briefly. So for the disciplines, I think everybody in this room knows that Paul was formally trained as a physician and as a medical anthropologist. Many of you may not know that he was also a self-proclaimed critical epidemiologist. And although the origins of critical epidemiology go back to the 1970s, I had never heard that term during my many years of education at the neighboring institution in the 1990s. But despite my ignorance about critical epidemiology, he welcomed the likes of me and many other colleagues who had been trained in a tradition of more reductionist epidemiology into the global health equity fold and into the department. He did caution us against the tendency of medical science and public health to favor, or he would say to fetishize, empirical methods that pursue quantification of an effect, the pretense that one could isolate the effect of a treatment, of a diagnostic, of an individual or community characteristic in the larger context of inequity and marginalization. So he offered a form of accompaniment to us, to our quantitative research endeavor, from the resocializing disciplines such as anthropology and history that had long histories in the Department of Global Health and Social Medicine. And these theoretical underpinnings and their ability to expose and subvert the structures that place some people at higher risk of TB or HIV or cholera or whatever disease we were studying were really essential to our ability to be able to complete the job of accompaniment. In the vein of the methods, I don't want to suggest that Paul's rejection of a disciplinary hegemony of quantitative methods meant that he discounted all quantitative research. He most certainly did not. He saw the benefits and the perils, but he would caution against one such peril that emanates from this socialization for scarcity that I think Brian mentioned in the previous panel. That bought into further fetishization of, say, experimental designs, experimental placebo-controlled designs when they were deployed as an excuse to ration resources and to ration proven interventions, like food for hungry, sick people, like individualized treatment for multi-drug resistant TB, like cholera vaccines during a cholera outbreak. Accompaniment meant that we had to find ways to simultaneously implement known interventions and yet generate compelling evidence for donors, policymakers, and other reluctant innovators. So the levels and dimensions, to me, the research accompaniment really requires humble engagement with the people who are experiencing the greatest suffering, the very ones who are most in need of the fruits of research, and the ones least likely to access it. Accompaniment entails their engagement in the definition of research questions and approaches, in ensuring that research advances their priorities and that their interpretation and dissemination of results are informed by their analysis. The second group that I think really, the second sort of level of this research accompaniment is those researchers and clinicians who work every day with those populations we aim to serve, who work proximally to the suffering. Researchers in low and middle income countries often face constraints in access to research resources, infrastructure, protected time to do research, platforms for global collaboration, and not least of all, funding and recognition. And accompaniment here to me means using our resources and influences to reduce these constraints or remove these constraints. And lastly, in terms of the engagement, and I alluded to this when I was talking about the methods, the long game of research accompaniment also entails engagement with those who bear the duty of implementing innovation that results from research. And by this, I mean ministries of health primarily, but also heavily influential groups like the normative bodies like the World Health Organization, and then donors that rely narrowly on the advice of those normative bodies in making decisions about who gets resources for care. Paul would remind us that these institutions are social creations, that they are built by and maintained by people, and therefore we have to work with them to overcome institutional resistance to progressive social change. And the simple part, the last part, is the purity of principle. I am acutely aware that I am not a clinician. Nevertheless, the clinical accompaniment standard that the previous panel discussed so eloquently, and they're sharing their own personal experiences, that guides my research decision-making. When I have doubts about what to do in research, how to handle thorny questions, which happens quite frequently, I might add, I return to Paul's core principles and critiques. I return to what Joya said not long after Paul's death, when I think we felt totally adrift and rudderless. She reminded us that it's no mystery what we have to do in service. Paul left us a roadmap, and that same roadmap applies to research. And when we're confronted with seemingly perverse decisions, say by ethics committees, that refuse to allow social support to research participants because it's considered coercion, we're reminded that the way to manage that tension is to continue to partner with organizations that make normative social support, and therefore that norm cannot be denied to research participants. So I just want to conclude by saying that to me, research accompaniment is clearly part of Paul's legacy, and that thinking about this, preparing for this panel with my esteemed colleagues brings back many memories of debates, Paul's wry humor, and yes, occasional stinging rebukes. Ultimately, Paul taught me, and I think many others, that research accompaniment is essential to the social response required to remedy the social suffering experienced unevenly in the world. Thanks, Dan.
Now you see what I mean. Imagine a 28-year-old hearing that. Steve Reifenberg. So Steve Reifenberg and I first met when I was, again, a GHE resident trying to launch a healthcare system strengthening effort in southern Mexico, in Chiapas, what would ultimately become Compañeros en Salud, or Partners in Health Mexico. And we were very wide-eyed and bushy-tailed then. And Paul wanted to help us. So he said, Dan, you have to meet Greenlight Steve. And I said, okay. So that was partially because he was the executive director of the David Rockefeller Center for Latin American Studies at Harvard University. And Paul never fully described or explained to me what he meant by Greenlight Steve. But what I learned was that when you partner with Steve Reifenberg, good things happen and things move forward. So at Harvard, then later when Steve was at the Kellogg Institute for International Studies in Notre Dame, I knew that if I asked Steve, do you have any students who might be willing to partner in this effort, he would invariably send us someone who was spectacular. And now we have almost a dozen examples of students who have come and left lasting impacts on work in Chiapas, Liberia, and even Immokalee during the COVID-19 pandemic with migrant health workers. But it's not just Steve's ability to spot talent. It's also his ability to excite their imagination and unleash their innate capacity to become a change agent that really made these placements so special. And to hear Steve talk about accompaniment in the classroom, honestly, it's a work of art. It's both grounded in the core principles, and very hopeful, but also dissatisfied with the status quo. And so Again, we see this dynamic of accompaniment as a philosophical stance and a rubric for programmatic design, standing firm but moving forward in a way that is both nimble and responsive, but also grounded and reproducible. Thank you, Steve.
Thank you, Dan. I feel like I should just leave right now. I actually even more feel like I should leave because I think I'm the only person that's not a medical professional on this entire panel. And I just have to say a word though about you mentioned about Paul's picking out nicknames. It's a little bit like Ingrid talking about everybody felt like Paul's friend, but Paul had nicknames for so many people. And I think it was a way of connecting, right? It was a way of accompanying people. It was a way of like, I was an administrator at Harvard University in the bureaucracy, and he made me feel like I was green light. So like, then you try to live up to that standard, right? You know, you kind of like try to rise to the expectation that this nickname has given you. And I think so many people that met Paul in some way or another got that sense that like, these great things are expected of you, and I'm gonna be there with you, and we're gonna make some incredible things happen. And I just feel like, you know, my life has been blessed, and I'm full of gratitude at the incredible things that have happened from getting connected with Paul and so many people at PH, including Dan and his wife, Lindsay, who work so closely with the work in Company Rose and Salute in Mexico. And so that Carol did such a nice job talking about research. I think I'll focus a little bit more on teaching. So I teach on international development at the University of Notre Dame. I feel that this idea of accompaniment sits at the center of what I teach, but also about how I teach. And this how I teach of, you know, walking with students, being present with students, going on a journey, a learning journey together. I think it's something really powerful. When I started teaching, I thought teaching was all about, you've got to be the expert on everything. You've got to have the answers for everything. And I think the most inspiring and wonderful teachers are ones that want to go on a journey with you. And so I think that image of walking together is so powerful. And as I was thinking about this panel just a little bit, I think about, you know, my own students at my university and many other university students here in the United States. And I think globally, it was mentioned a little bit about the mental health challenges. And it's something like the statistics are pretty consistent across US universities internationally, that something like 60–80% of students feel some amount of distress. Some 20% every day feel so much distress that it's difficult to act, to move. And so as an educator, to be able to have that model, a little bit of walking together, sometimes I feel like when I'm sitting in my office across the table, there's a student, whether it's personal issues or something in the broader political context, or that they're a senior and they don't have a job and they're feeling really stressed, to be able to just go out and say, let's take a walk and a talk. And it's something Paul used to talk about. The best things that he did were go on these walks, to go a long way in Haiti or in Rwanda to visit a family. I feel sometimes like channeling that just a little bit on my walks and my talks. And then it's like also that these young students, and I'm now 65, I've had 4 back surgeries. I have a kind of a foot that doesn't work quite right. And so they have to kind of accommodate me a little bit as I'm trying to accommodate them and walk with them and accompany them. And they're in a certain way, I'm accompanying me. And so if I wanted to talk about one thing, I think I'll just lean in a little bit to the story that Dan mentioned. And I think Paul, who loved telling stories to capture something, loved the story of the work in Chiapas, Mexico. And I'm just going to tell it briefly because I think it's a story of accompaniment. And I want to make the case that it's the story of accompaniment is I've talked a little bit of this idea, which I think is really intuitive, like that when you accompany somebody, you're walking with them. And you kind of intuitively think of that as an individual act. And I think what the power of this idea is you kind of take that individual act and you can think at an organizational level, and you can think about that influencing policy. And I think that's what's been the brilliance of so much of the work of PIH, but I'll use the story of Chiapas. So Chiapas is a poorest state in Mexico, in the southern part of Mexico, incredibly beautiful, mountainous, kind of tucked up next to Guatemala. And until 15 years ago, it had all of these kind of cinder block medical clinics that didn't have any doctors or nurses. And it was because it was so rural, it was so difficult to get to. And like in other parts of the world, that you're in your final year of medical training before you're finally licensed as a doctor. You're called a pasante, passing through, you get your medical training. And something like 70 or 80% of the medical provision in rural areas is from pasantes. There are almost none in Chiapas, or in this part of Chiapas at least. And companies in Salud said, we're going to do something organizationally. We're going to not, and actually it turns out you can pick where you go based on your GPA. And so surprisingly, medical centers in big cities get lots of great people. And as you move further out, so we're going to go to the best public university, go to the best private university. And we're going to invite these really talented people in because there's a great challenge here. There's something that needs to be done. And we're going to build a community of these people. And we're going to keep them in training. We're going to get together these people in these local communities once a month and bring them back together. And more than that, we're going to create community health workers, a dozen in every one of these towns of 1,000 or 2,000 people, called accompagnateur. So that would work with the physician. And suddenly, from not being able to attract people, they suddenly have people not only coming for 1 year, but wanting to stay multiple years. And one of the people that stayed in those early years was Valeria Macias. And Valeria was in one of these communities and trying to accompany her patients, working with the accompagnantes, and then also kind of referring patients that were there that needed a surgery or something else to other parts of the system. But she started to recognize that these patients that were being referred, that had a right to a hysterectomy in the major city, that it wasn't like a small percentage of them were getting surgeries. None of them were getting surgery, not a one. Because it turned out when you started tracking it, there were so many steps of getting transportation, of having a place to stay in the capital city, of getting the appointment with the surgeon, with the anesthesiologist, of having the right test, and all these things. And you miss one of those, you don't get surgery. So what they do, Valeria started a program called the Right to Healthcare. And what it was an accompaniment of walking through each step. How do we get transportation? Where does this person stay? Let's call ahead to make sure the doctor and the scheduler know that they're coming, so they don't say, oh, these people from the rural areas, they never show up. And step by step, they started to go from 10% to 30% to the majority of these patients getting the surgical and other care that they were entitled to under the Constitution. And then the really remarkable thing, so that's how an organizational thinks about it. But then the really remarkable part is you start seeing systems and patterns, and those patterns you can address. And so that's when you start looking at these policies, and suddenly because every one of these clinics is a government clinic, and all of a sudden you can start working with government actors on thinking about broader policy issues. And so that idea from that individual perspective, organizational, and at the policy level, all of those kind of really coming together in this accompaniment approach. And the final thing I just want to say, using the Chiapas case, is right now it's like in other parts in the world, a really difficult time there. I've been there 5, 6 times, gone with my family, gone with some people here today, and always felt very safe traveling around. It's a wonderful community. And in the last couple of years, there have been some kind of drug gangs that have come in, have begun to fight over territory. And suddenly, you're faced with some of the most difficult situations that endanger all kinds of people. And so last night, I sat down with Valeria Macias, who a dozen years ago started as a junior doctor in Compañeros en Salud in Chiapas, and today is the executive director, and asked Valeria, well, what should we do? Because it's even hard for these doctors to be in place, and where are people going? And what should we do? And she said, here's what we should do. Number one, not lose hope. We need to stand with people in these difficult, audacious times with an audacious vision. We need to support the community health workers, that we now have this talent in every one of those communities. We have to support the community leaders that are coming and going to bring drugs and medicine and other things. We need to continue to support the maternal clinics and the birthing centers that we've established. We need to continue to be in dialogue with government officials about what we can do together. We need to learn from our colleagues within our own organization, like in Haiti and elsewhere. How do you continue to be present in company, even in these most difficult of times? And so it's with just this incredible awe that faced with ever expanding challenges, this accompaniment model just says, you hang in there. This is the long-term play. It'd be easier to go someplace else. I'm sure we could have a better return on investment going next door to Oaxaca or something like that. But the commitment is with this community. And in that creative commitment, some amazing things happen.
And, you think about how after meeting an administrator at Harvard, that relationship could have ended in a transaction. Here's a grant. Here's an opportunity to write this paper. Instead, now look, 15 years later, and we're together walking through the challenges as they arise, from narco-traficante violence to whatever's coming next, right? What's coming next? Let's do it together. So then me, 20 years of being at Harvard and the Brigham and Partners in Health, and I finally get to meet Sachit Balsari. He's the newest addition to our family, but definitely is aligned deeply and philosophically. So he's a practicing emergency medicine physician at Harvard, an associate professor at the medical and public health schools. We got together to speak, and I got to learn more about his work. And I was delighted to realize that after thinking about this for so long, I could still learn yet new ways in which accompaniment can be implemented. So imagine that you hold this position and that you want to understand the experiences of working women in India during the COVID-19 pandemic. The classic thing to do would be to interview them, record their responses, code their responses, and try to pull out things that you can share with the world. That would get published, it'll get cited, it would be great value in the academic literature, but something is lost in that process. Sachit said that he didn't want to do this because this process of boiling down these data, while useful, was going to blend out these women's authentic voices. He recognized the value of the world hearing directly from them, so he and his team created a traveling exhibition called Hum Sabik, which in Hindi means we are one, the rallying cry of SIWA, which is the Self-Employed Women's Association, of which these women are members. This multimedia program is now touring the world, bringing their voices to lands far from India and elevating their stories, but in their own words. So there's a lot of other examples, and he'll tell us some more, but one more that I thought was really incredible. After Hurricane Maria hit Puerto Rico, the official reports were saying that there was probably only 59 deaths or so. Sachit and his team were hearing that it was probably much higher. So they did a house-to-house survey and found that the death toll was actually over 4,000. This, of course, had major political ramifications, but I just want to point out that this effort was grounded in the desire to have people's voices heard, and it embodied what Paul called the view from below, or a view from below. So Sachit's philosophical stance is that he stands firm in his desire to speak with the communities he works with, not for or about them. Sachit.
Thank you. I'm very much the outsider, but feel very comfortable here. I'm reminded of the mythological Indian student Eklavya, who was not allowed to enroll into class, but he loved the curriculum so much that he stood outside the classroom for years and learned everything that the professor taught inside. And only now, when I was forced to examine my work, I see so much that I have learned from Paul's actions, Paul's writings, and Paul's life. So thank you very much for including me here. Paul's work, of course, was guided by liberation theology and a framework that he writes about as, observe, judge, and act. The observation piece was something I was quite familiar with before I did this work with the women in the informal sector. I trained with colleagues here in human rights advocacy work. Bearing witness was something that the Red Cross always does. You show up in regions of disasters, wars, you bear witness. I've been to the Syrian refugee camps in Jordan, to Iraq, to South Sudan, to hurricane-affected areas in the Caribbean and Central America, across sort of ravaged portions of South Asia. And it felt like I had, over 20 years, finally understood how to tell these stories, how to capture these stories. And so when the Self-Employed Women's Association reached out and they said, can you help us chronicle all we had to do to survive the pandemic? Because in India, if you remember, there was a draconian nationwide lockdown for 2.5 months. And that meant that the vast majority of India's labor force, 90% of India's labor force, is in the informal sector, faced sudden food insecurity within a matter of days, right? As they lost wages and they were all forced to sit at home. And yet these remarkable women, 3 million of them, who were organized in a range of trade unions and cooperatives, survived. And to survive, they launched multifaceted response in health and food security and education. They, recognizing that their kids did not have a digital device for Zoom school, came up with an asynchronous education program where they WhatsApped a program to each family every evening. The kids would do their work, record their homework, and send it back the next evening, and it would be graded overnight, and on and on. They had sort of financial no-interest loans given to these women to help stabilize their businesses. And so I went there a couple of times, understood, got a sense of what they had done, and came back very confidently, designed a quantitative survey and a qualitative survey. And we interviewed 1,000 households. And before we launched a qualitative survey, I decided to go down. I spoke the language and said, let me test this instrument before the students do, from a neighborhood institution that we will not mention. I very quickly realized that the instrument was not going to work at all. These women looked me in the eye, spoke for 45 minutes. I was on question 2, extemporaneously, experientially, with a substance to noise ratio that was the opposite of most of our colleagues on campus. And I was just not going to be able to document this quickly enough, same language, different dialect. And so I began recording this for my own notes so that I could come back and synthesize the data. And I did. I came back and I was listening to these videos. And I don't know what prompted me to even record them. I should have just pressed voice memo on the phone. But the week before, I had watched Anna Devere Smith's play at the ART, and that must have been subconsciously in my mind. So I hit video instead of audio. I mean, I am faculty at Harvard. I'm allowed a little bit of narcissism, and so I had a tripod set up and I recorded these. But when I was listening to these videos, I quickly recognized that I did not have the vocabulary to tell their stories. I did not have the vocabulary to capture their expressions, and I certainly did not have the vocabulary to capture the silence and the tears in those stories. So I went back to them, and I said, these are very powerful stories. What do you want me to do? And they had very clear instructions. They said, go to Geneva and tell the International Labour Organization about what our lives are like. Go to London, go to New York, tell the Indian diaspora what their actions and inactions do to us, and come back to the villages and show our neighbors what we do. And it was then that I began to recognize, and I did not have sort of the normative frame to understand this, that I could no longer speak about them. And it was not my place to speak of them either. And what I had to learn to do was to speak with them. And I very quickly realized that I was stumbling into an academic debate that had raged for several decades. And in the late 1980s, Gayatri Spivak first asked the question, can the subaltern speak? And whose job is it to speak? And 10 years later, Linda Alcoff says, there is a problem when you speak about others. Should we be speaking of others? Should we be speaking about others? Should we be speaking to others? Or should we be speaking with others? And I felt that what Paul did well was he spoke with others. And you are all testament to Paul's belief that he always spoke with the communities that he served. I find that we are doing a very poor job, and this crowd is an exception, at this university in teaching our students to learn to speak with. There is that hegemony of the quantitative sciences, there is the hegemony of the quick, the expedient, the low-hanging fruit, the easy publication, over sort of these decades of commitment to the societies. Our data sets, which is where, and you know, Luis has heard me say this often, our students begin with data sets to ask a question. They do not even know the communities that the data set represent. You are all an exception to that experience. And I very much hope that going forward, especially in the times that lie ahead in a few months from now, we cede no space, because we need more of us to accompany. Thank you for listening.
You know, how wonderful that we continue to have these conversations with more voices. And I think that call for a broader table to speak together, I think that that's probably the main take-home point for this entire symposium. And as we continue that conversation, I'm drawn to maybe reflect a little bit with you guys on more challenges, speaking about what's coming in 2025. You know, I don't know if you guys know this, but in the second half of Paul's famous quote about walking, breaking bread, but not for a little bit of time, for the time it takes, there's another paragraph. There's more. He keeps going. Yeah, isn't that amazing? He didn't stop there. So he said, even good intentions and long experience sometimes fail us. Accompaniment with discernment also requires asking tough questions. Are we doing the right thing? Have we carried through? Have we followed up? Do we understand as fully as we might? Are we doing enough? Is the problem solved? If an effort is not laden with anxiety, it's probably not accompaniment. Or it's just the beginning of the effort. So accompaniment can be really tough. And sometimes the context in which we work, be it the regulatory frameworks, the financial pressures, the political backlash, it leads us against the values of accompaniment. What are your reflections on that? And what advice would you give our conference goers as we enter into this brave new world?
I'm going to start with, I don't know if it was so much a nickname Paul used for me, but Paul often called me a contrarian. And taking Steve's view of Green Light Steve, I'm going to view that as, that was a call to action for me. That Paul wanted me to be contrary, maybe not so much with him, but with the institutions that who really need our encouragement for progressive social change. And I think, you know, Steve also gave the terrific example of Valeria's attitude toward the current situation in Chiapas. And it's really, it is about remaking our stance. Well, not our stance is always the same, but coming up with new tactics, trying different strategies, but it is all going to continue to be about standing in solidarity with those we've committed to serving. At the same time, we're really trying to induce the progressive social change in institutions. And I don't think that's going to change. In fact, I think we're going to be even more desperate in the near future.
Yeah, and I'd just like to add, I think, thanks for asking that question. And Because I think sometimes when you hear the language of accompaniment, it sounds, and I'm from the Midwest, it sounds really nice. It sounds like, oh, isn't that nice? You'll help other people and be kind and stuff like that. But I think Paul was getting at, and he used the language that it's, kind of accompaniment is tough and gritty, tough as nails. And that it's not this just being nice, but I kind of think of it sometimes in negotiations, just like I was talking about walking with somebody in negotiations, sometimes there's this idea you negotiate across this table with this person that you hold a different view from. And this idea that if you can come around to the same side of the table and put the problem in front of you and say, we don't see this thing the same side, but let's look at this problem, let's honor each other. I think it's a really powerful shift. And I think the accompaniment approach is not to say that Paul fretted a lot, because people have, with the best of intentions and social visions of where you want to go, different ways about even how you think about getting there. And that you can kind of come together and sit on the same side of the table and talk this stuff through, this hard stuff through, and more hard stuff coming, but not just demonize the other because they don't hold the same belief that you have. And I think that idea of, again, walking together, looking out into the future, thinking in audacious ways about the possibility, and speaking language of hope, even as you hold views that aren't always consistent, is really a powerful kind of motif to take us into the future.
About how do we address structural barriers. I mean, Paul's work, this department is testament to the fact that this is possible. I think we need to do more and not be limited by our imagination. A couple of decades ago, when problem-based learning was first introduced in the medical school and we decided to shrink the curriculum, it must have been anathema to think that you would, push all of basic sciences into a few years. Why you can graduate from a public health school without ever working in a community is mind-boggling to me. Why Roxbury does not have the best public health indicators in the United States is mind-boggling to me. And so our work is not complete until we have sort of gotten out of our safe spaces here and worked with the communities. And there's a critical mass of us that do that. And I think we keep nudging for space where that is not the exception, but the norm at schools like this.
It's a call to action, very clearly hearing the call to action with clarity on where to stand and also rubrics for moving forward. So perhaps in the Midwestern fashion, we'll end with some positive notes. People, the thousands that are joining in and streaming online, they want to understand how they can live in this legacy. They may not have known Paul. Unfortunately, he was taken from us too soon. But what advice would you give them so if they wanted to fully live within the values of accompaniment?
So one starting point, I think, is, and maybe I represent not being a medical professional, is that there are so many roles of people to be able to accompany one another and to move forward in this vision of, with a preferential option for the poor, with a commitment to the most vulnerable, to seeing our way forward. And I always think that for a while with Paul, we were working on a kind of a project about accompaniment, and there were going to be a number of chapters. And what happened is, every time I turned around, Paul would have talked to another person, kind of a financial officer in Sierra Leone, or a physical therapist, something. And then he would say, oh, you have to write a chapter on accompaniment because what you're doing is accompaniment. But I think there's something really powerful about that. It is not just providing medical care that is the model of accompaniment. I think every teacher that does it, every physical therapist that does it, every parent that does it, every policymaker that does it, is this idea that the proximity matters, the connecting with communities matters, and that taking that insight of being proximate really helps move you into the future, and that it's everybody's job. It's not a certain profession's job.
I think physicians have it easy. You have the opportunity to try and make the world better, one person at a time. And Paul did this, of course. I think it's okay to dream big, but act locally, and act small, but act authentically. Even Gutierrez speaks of genuine change beginning in small communities. He says, right, change is rooted in small communities. Almost all social movements that we admire sort of began small. Mahatma Gandhi talked about changing himself, right, and leading the world with sort of his change. Ila Ben Bhatt, who started the Self-Employed Women's Association that I've now gotten to know, she talked about 100-mile communities and sort of smaller networks in our global world. I think the idea here, therefore, is to not go big, but indeed to return home.
Thank you so much, everybody, and thank you for your wise thoughts and also your open hearts to this idea of accompaniment in research and pedagogy.
Please welcome Dr. Jim Young Kim to the stage.
I was asked to just say a word about Jim. What can you say about Jim Kim? He, is a luminary in these spaces, co-founder of Partners in Health, president at Dartmouth, was his seminal work at the WHO, and then also the World Bank. But I guess maybe this is my vanity, Sachit. I know him as my first boss, Jim Kim.
Thanks so much, everybody. It's just, it's so great to be here with all of you. Let me start by making some introductions. I just want to recognize a few of Paul's family members. First, Didi, can you stand up? And his two sisters, Jennifer and Peggy, but as he would call them, the classic nicknames, Jodsy and Petsy. Can you guys stand up? So I'm really privileged to be able to just say a couple of words. I've listened to this great panel, and I want to just reflect on how I learned about accompaniment from Paul. And so, Vikram, your words were wonderful, and Arthur, my mentor of now over 40 years, sir. It's true that a lot of the inspiration came from Paul's engagement with liberation theology. But really, everything in his educational process led him to this very subtle and at the same time very deep sense of what accompaniment meant. I'm sure Arthur knows this, but Paul went through psychoanalysis for about a year when he was an undergraduate. He worked with a great psychoanalytical anthropologist named Weston LeBar. And Weston thought that Paul was such a promising student, but he really wasn't going to get anywhere until he went through his own process of psychoanalysis. So he was literally on the couch for about a year. Now, he would never admit it to me, but what I suspect is that after about a year, he started doing more therapy for the analyst than he was getting himself. Can't you see it? I mean, I kept poking him saying, come on, Paul, that's what happened, right? And he'd say, no, it was very helpful. But he went through that for a whole year. And as Arthur knows very well, he came out of Duke wanting to be Arthur Kleinman too. He was going to go into psychiatry, and he was going to do psychiatric anthropology in much the way that Arthur did. So, at root, the notion of accompanying someone and just listening and just saying things like, wow, that must have been difficult for you, that came very naturally to him. And of course, then the medical training, the medical training was perfectly, the highest aspiration for the medical interview you learn in your first 2 years. And you never actually do that again. But in the first 2 years, you learn about long silences. You learn about, just saying things that are supportive, getting people to talk. So in every aspect of our training, the notion of just being with people and bringing the weight of your presence, the weight of your listening attention, was something that that was just part of every aspect of Paul's education. Now, my role and my job with Paul from the very beginning was to sort of think about how to take things to scale. And, as everyone who knows me knows very well, and as I readily admit, the only skills I have left are scheming and plotting. But it turns out that can be useful at times. And so lately, and Vikram and Arthur know this very, very well, I have become very involved in mental health for a lot of unexpected reasons. The president of Korea asked me to help him, and I've just discovered not only a mental health, but a mental health crisis that has led to a demographic crisis, the likes of which we've never seen before on Earth. A total fertility rate this year, which will be less than 0.7, so something like 0.65, rates that we've never seen before. And it has to do with a crisis in mental health that goes in so many different directions. And I don't want to talk about that today, but in terms of my scheming and plotting hat, what we know is that the need for accompaniment throughout the world, in rich countries and poor countries, has never been greater. So, what we learned from our friend Vivek Murthy is that if you answer yes on a questionnaire that you are lonely, that reduces your life expectancy, the equivalent of smoking 15 cigarettes a day. So just saying you're lonely is a 3/4 of a pack a day habit in real epidemiological terms. The other thing that we're seeing, and again, this is something that I've only woken up to recently, is that starting in 2010, with the advent of the front-facing camera on the iPhone, which was copied soon after that by Samsung, that the front-facing camera on the iPhone linked to the launch of Instagram has led to a spike in mental health issues among especially young girls, but in that Gen Z population, those born between, I think, 1997 to 2012 is the general range, that their upbringing has become fundamentally different. And everywhere that you get both access to smartphones and high-speed internet access, you see this rise in anxiety, depression, but also suicide, right? And if you want to know the worst piece of data I've ever seen, is that in Korea, that had, of course, everyone had a front-facing phone on their Samsung phone, and access to high-speed internet access was higher than any other country in the world. The suicide rate for grade school children went up 5-fold starting in 2010. Right? So we have that crisis as well. And it turns out that young children, they reach 90% of their adult brain size by the age of 5. And then from 5 until you become an adult, you spend all this time interacting with people. This is over millennia, interacting with other people to make the connections. What a friend of mine of many, many years, Sebastian Sung, has called the connectome. And building that connectome requires actual interaction between people. But since 2010, that interaction has moved dramatically to online. And so the kinds of distortions that this has created, we're not sure. Now, this is all part of my scheming and plotting. Okay, so we've got this crisis. We've got the rise in nativist political movements, increasing isolation of the elderly. There's a phenomenon in Korea, Japan, and China, and specifically, it's the same Chinese characters, and it's sort of isolated deaths among the elderly. So there are companies in Japan and Korea that go around when you start smelling something under the doors of people living in apartment buildings because they know what's happened. Someone's died alone and they've got to go and they've got to clean it up, right? So because of this desperate need for people who are trained in accompaniment, I think we have an opportunity. So other trends, artificial intelligence. When I was at the World Bank, we studied this carefully because the question was, how many jobs will be eliminated by artificial intelligence? And probably the best work has been done by my old friend and former deputy, who now is the head of the IMF, Kristalina Georgieva. So Kristalina says about 40% of jobs in the world will be eliminated by AI. And you know, it's all a best guess, but this is the best data I've seen. But the loss of jobs will be 60% in high-income countries, 40% in middle-income countries, and about 25% in low-income countries. And so as those jobs get eliminated, what are the kinds of jobs that will grow? And this is great work done by Anne Marie Slaughter at Princeton, that what should grow is the care economy, right? In other words, professionals who we teach in how to accompany others. Now, you know, what might that look like? So I'm personally a huge Vikram fan, and I think his Empower work should be sort of given to everybody. I mean, we should train everybody in the kind of cognitive behavioral therapy that he showed can have dramatic impacts on anxiety and depression, even in the poorest Indian villages. And so among the opportunities in terms of helping people to accompany others, one of them, for example, would be in taking something that I'm sure you were involved in this, but the development of something called psychological first aid. Right? Psychological first aid was developed at the World Health Organization by Shekhar Saxena when he was the head of mental health there. And if you look at what's happening on campuses, so in the 3 years that I was at Dartmouth, and Brian remembers them sometimes fondly, not so fondly other times, but in those 3 years, there were no suicides. The 10 years before that, there were no suicides. And the 10 years after, there were no suicides. But in 2023, there were 8. Right? And as you may know, when there is one on a campus, it can act almost like an infectious disease. There can be more suicides. And so what I've been talking to university presidents about is why don't you require psychological first aid training for every single freshman coming in the door? And what that would do, it's not so much that they're experts on mental health, but it trains people to look at others differently and ask yourself a different kind of question. If we could make it the cool thing to do, like learning CPR or learning how to be an EMT was a cool thing to do for a long time, then you might be able to get this Gen Z generation whose brains have been fundamentally shaped by the online experience to look at each other differently. That might be the coolest task that you have. Now, the reason I say all this in the developed countries is if we can convince people that teaching people how to care for others in the way that Paul did, if we can make that something that people understand, wow, if we do this more effectively, because anxiety and depression are the biggest drags on productivity in any company, if we can teach people how to do this in the richest countries, then I think it'll be much, much easier for us to make the case that paying for accompaniment, that making sure that community health workers are the ones that are supported the most, that's an argument we could win. Now, just today I met Dr. Madhukar Pai. Is Dr. Pai here anywhere? Madhu? Anyway, so I didn't know this, but he did these amazing studies on the importance of food in TB treatment outcomes, right? And so in 1996 it was, Paul and I used to have what he'd call the food fights, that we would fight with the rest of the TB community about whether you provide food to people who are suffering from tuberculosis. And the entire TB community was just absolutely certain that there was, quote unquote, no evidence and no reason to provide food for these people who are literally having their bodies consumed. That's what it's called. It's called consumption, right? And I just, I remember how angry they were. And they said, well, maybe vitamin supplements, but not food. So Dr. Pai did this amazing study where they provided food to people who were suffering from tuberculosis. and they had 60% decreased mortality. They had 40% decrease in TB in households. And the adherence rate, which in India had been notoriously low, the completion rate for TB therapy went way up to 93%, right? And so Paul, you know, if I were to ask all our buddies at PIH, what would Paul have said? I think everyone would agree. He would have said, duh, 10 years later, right? Well, it was actually 15 years later, but I am certain that the data on accompaniment will be just as powerful someday. But in the meantime, I look forward to scheming and plotting with all of you to find ways to get this supported at the level that it should be around the world. This has always been my job in PIH and in working with Pell. And first of all, it's a wonderful milestone for me because this is the first time I've talked about Paul without crying in public yet, anyway. But as we go into our break, I will just say, every day I miss his accompaniment, every single day. And if we can make accompaniment something that is a bedrock part of all global health programs going forward, then I think we would have done right by our great friend. Thank you.
Thank you, everyone. We will take a 15-minute break. There's water in the lobby. Turn your attention to the screen for a short video message from Dr. Tedros Adhanom Ghebreyesus, Director General of the World Health Organization.
Dear colleagues and friends, I'm honored to join you in celebrating the work of our late friend and colleague, Dr. Paul Farmer. Paul was a humanitarian, a public health pioneer, and a tireless champion of equity and health as a human right. His work helped to empower communities and make life better for people around the world. His concept of accompaniment included the ideas of service, solidarity, and partnerships for justice. Health and care workers embody the principle of accompaniment. An empowered, diverse, and protected workforce is better able to do its job with compassion and empathy. And that's better for patients and for our shared goal of health for all and all for health. To harness their full potential, the health workforce needs adequate investments in education, equitable employment, and opportunities for leadership. Accompaniment also extends to the determinants of health, including measures to address healthy housing, indoor air pollution, and water and sanitation. Paul's concept of accompaniment is more relevant now than ever in a world faced with overlapping humanitarian crises, conflict, and extreme weather events, where people who are already vulnerable become even more so. As Paul never let us forget, people must be at the center of everything we do. I thank you.
Please welcome to the podium, Dr. Joe Radigan.
Hello, everyone. I am Joe Radigan. I am the chief of the Brigham and Women's Hospital Division of Global Health Equity, and I also serve as the chair of the board of directors of the University of Global Health Equity. Before I start my remarks, I would like to recognize someone who couldn't be with us today, but who is intimately connected with both Paul and Jim O'Connell. In the 1990s, PIH, Paul, Jim, and Ophelia were little known outside of a few small social justice and global health circles. That all changed with the publication of Tracy Kidder's New Yorker article, and his book, Mountains Beyond Mountains. PIH suddenly was no longer a lone wolf crying in the wilderness, as Paul would often refer to us. And it suddenly became a national phenomenon. The book became required reading in high schools and colleges across the nation, and it introduced an entire generation to the cause of global health equity. Tracy's latest book, Rough Sleepers, similarly has brought Jim O'Connell and the Boston Healthcare for the Homeless program to a much larger audience. And we all hope that it will do for BHCHP and the movement to end homelessness what it did for Partners in Health and the move for global health equity. So please, even in his absence, let us thank Tracy for these wonderful gifts. I was asked to offer a brief reflection on what Paul taught me about accompaniment, which is a bit more difficult to do than it sounds, because Paul taught us all so much about accompaniment. He taught us not just through his writing and his words, but through his actions. His practice of accompaniment was active and infused with the act of caregiving. It was not just being with, it was also being for. One lesson he taught me was how much this work is unseen and unadorned. For example, Paul would answer his phone no matter what time of day it was and no matter what he was doing if he thought the caller needed him, and often the caller did. He seldom sounded impatient or annoyed at the interruption, but instead would ask a few quick questions and either wrap up the matter right then or promise a call back. There was never any feeling of frustration I could sense from him, despite watching him occasionally field multiple of these calls, one right after the other. He also welcomed requests from his patients or his friends abroad to help them procure some particular item that was difficult to find in their community. And I know most of you are aware of this, but he tried to hide it. I watched him get coffee makers, electric toothbrushes, iPods, iPads, and all manners of headsets to bring to his friends and his patients. He was also well known for giving some of his personal items away on the spot. I remember him describing giving his iPad away to a young woman who was ill, saying to me, "Why should I have an iPad when she doesn't?" Paul would never call attention to his generosity, and he was often secretive about what he was trying to find and for whom. He also made it a priority to visit anyone he was even remotely connected with who became sick and hospitalized, and often showed up in their rooms long after visiting hours were over. One of my favorite poems is called Those Winter Sundays, and it's written by Robert Hayden. I first read it when I was a teenager, and I find myself returning to it a lot since Paul's passing. It's a very short poem told through the eyes of a man who was looking back at his childhood. In the poem, he remembers the many small things that his father did to care for him, that he didn't notice as a child, and that he never was able to thank his father for. The poem ends with the line, "What did I know of love's austere and lonely offices?" And it is these austere offices, these simple duties, that are at the heart of accompaniment and that Paul always embraced. He embraced them quietly and without burden, despite how busy he often was. And he did not do this for praise. He did it because it was simply the right thing to do. Although he wrote extensively about accompaniment, it was watching him in these moments that helped me understand how deeply he believed in it and how deeply he lived it. Thank you. And now it is my great pleasure to introduce our keynote speaker tonight, Dr. Jim O'Connell, who practices a similar form of accompaniment as Paul did. Dr. O'Connell serves as the president of Boston Healthcare for the Homeless program and is a faculty member at Harvard Medical School. Dr. O'Connell graduated summa cum laude from the University of Notre Dame in 1970, received his master's degree in theology from Cambridge University in 1972. After graduating from Harvard Medical School in 1982, he completed a residency in internal medicine at the MGH. In 1985, Dr. O'Connell began full-time clinical work with individuals experiencing homelessness as the founding physician of the Boston Healthcare for the Homeless program, which now serves over 11,000 people who are experiencing homelessness each year. With all of his colleagues, Dr. O'Connell also established the nation's first medical respite home for homeless persons in 1985, with 25 beds that were originally at the Lemuel Shaddix shelter. This innovative program now provides acute, subacute, and palliative care in the program's 104-bed Barbara McGinnis House. Dr. O'Connell has served as National Program Director of the Homeless Families Program for over 8 years. He is the editor of the textbook, The Healthcare of the Homeless Person, and his articles have appeared in numerous journals, including the New England Journal of Medicine and JAMA. His first book, Stories from the Shadows, Reflections of a Street Doctor, was published in 2015. Please welcome Dr. Jim.
Thank you very much, Joe. And it's kind of humbling to be here because I'm now among people I've looked to for years as the heroes in this world. And for those of us sort of working closely in Boston, we feel totally in solidarity with you and really appreciate what you do. And to be here today is just a treat. In fact, I feel a little bit like after listening to those panels that I don't have much to add or much to say, but I'm going to give you the local version if it's okay. So, with some horror, I have to realize that I've been doing the same job for 40 years. And as I go back to the beginning, because that's what I met Paul way back in the very beginning, but I was finishing residency, wanted to become an oncologist. You may know this story. And I got called into my chief of residence office. It was John Potts, who's one of the world's most amazing people, and Tom Durant, who was a doctor at Mass General, who was also involved in a lot of international care, did all the USAID care. And they assigned me to go to join this new program in Boston, which was a Robert Wood Johnson Foundation program, trying to figure out how to go out and take care of homeless people before they came into the emergency rooms. And there were 19 cities around the country that got these. Anyway, I didn't know what to say when when you get called into your chief's office, the questions are rhetorical. So I said, sure, I'll do it for a year. And he delayed my fellowship for a year. And I figured, good, I'm going to have a chance now. I'm 37 years old. I didn't get to medical school till I was 30. And there's a story behind all that. So I could it was my year of giving back. I was really kind of thrilled to be able to do that. But I had no knowledge of homelessness, didn't know anything about the community. And I'm you mentioned one of the other things. I went to Harvard Medical School, which I loved, but I never stepped inside Roxbury. So, there was a world that I just never got to. Anyway, I started working and realized that the program had been put together by the mayor of Boston, it was Mayor Flynn, but the foundation had required that he have a group of stakeholders who would tell him how to do the program. I didn't know anything about this, but this is a later version of the homeless people, they were currently homeless at the time, who put together and decided how they wanted to be served. Now, I had a completely different idea, just so you know. So this was shocking to me to find out that I couldn't do what I wanted. What they said, among other things, they had gotten together with the mayor and they were so suspicious of all of us that they got Hale and Dorr, the big law firm, to do this big document in which they said, here's what we need in order for us to agree to do the program. And the most important thing they said, and this is 1984, is we want healthcare to be a right. We want it not to be a social justice issue, not charity. And as you can imagine, when I first started, I had all my friends ready to volunteer. We had it all set up of who was going to be there on Mondays, who's going to be there on next week. And I had friends who were going into dermatology, and it was going to be great. But the first thing I learned is we could use no volunteers because to them, volunteering smacked of charity. And they wanted the same thing from the healthcare system that most of us would want, continuity and care and consistency. The other thing, look at that, we couldn't use any students. And all this lasted for 5 years, by the way. So the first 5 years, it's kind of what we had to do. And they didn't want students because the perception of homeless people at that time was that students came and did physical findings on them at the shelter, learned how to feel livers and all that stuff. And then they all did their careers somewhere else. And they didn't want to be guinea pigs anymore. And I'm coming out of the world where I was just a student. Students are part of everything we do, what invigorates all of us. So it was a real hard one to do. Also, no research. Think of that. Like we could go over that, but there was a real tension between advocates and the researchers at that time. And they didn't want us coming with more research that would get in the way of what advocates wanted. And the last thing was we could not do mental health services. So Jim, Kim, wherever you are, and Vikram, we were not even allowed. I couldn't even write a script for an antidepressant back then because there was this issue where the homeless people and advocates were so angry with the government and the Department of Mental Health for not providing the services that had been promised in the community that they didn't want us to let them off the hook. So that was the beginning of how we started. And it was really interesting for us because I'm coming out of, fast-paced residency. And I know Dr. Nardell is here. And so I get to Pine Street Inn. Pine Street Inn's got 800 people. It's chaos. I remember coming out of the ICU. I thought I was God's gift to medicine, because just finished doing I was a senior medical resident in charge of the ICU. 6 blocks down the street, I'm at Pine Street thinking, how hard can this be? And it's chaos. It's total chaos. And I realized I had control of nothing. And there were these amazing nurses. And so, and I should preface everything I'm saying as I've learned from nurses, whoever the nurses are. Thank you for all of that. But the nurses had this clinic there where they were taking care of people. And I had to spend 2 months not doing doctoring, but soaking feet. And that was their way of saying, you've got to unlearn what you've learned. You've got to go slow. And, soaking feet puts you at the foot of the person you're serving. It's very comforting. And you're not in the private space that, the length of a stethoscope away from somebody's most private spaces. And then I couldn't ask any questions like, are you hearing voices or, all the chief complaint things you're trying to solicit. So I had to be patient and listen. And I have stories I could tell you about what happened, what evolved, but it taught me a huge amount. Basically, that until you were one of them, till you engaged people and they knew you were there to stay, they weren't going to tell you anything and they weren't going to trust anything you did. So anyway, we also at that time, and Dr. Ed Nardell is here and he remembers this all too well. This was we had an old x-ray machine at Pine Street Inn because there had been traditionally episodes of TB that would break out. When I first got there, I saw this man, the man whose x-ray this is, I'd seen a couple nights before when the staff had been worried about him. They said, look, we're really worried about this guy. Can you look at him? And remember, I'm trying to show them that I'm a good doctor. So he had no vital sign changes. He was really, said, I have a cough, but he was a smoker. He said, I've had that cough forever. He felt fine, wanted to get out of the clinic. And so I told the staff, I said, he looks okay. I can't. And by the way, I listened to those lungs with my stethoscope, and in a shelter, you can hear air moving everywhere. So it was not, I didn't do whispered ventriloquy, which I should have done. So they brought him back a couple nights later and they said, he just doesn't look right. And I had to learn 2 things there. One is that when somebody in the shelter tells you somebody doesn't look right, you have to turn the volume way up. And that was what I just didn't understand. They knew what was going on. I didn't. And then the value of an x-ray, this was the x-ray of that man. I'd sent him out of the clinic 2 nights before. And you all know this all too well. I mean, he's even a right upper lobe pneumothorax there. And you can, it's just cavitary TB. And he became one of the cases that turned out to eventually be 60 cases in the shelter of pulmonary TB that was INH and strep resistant. This is 1984, 85. And all of a sudden, I realized I'm useless. I can write a script, but this is, at those days, it required 4 medications every day for 18 months. That's what you had to do. And there's 60 people, and then 40% of people in the shelter converted their PPDs from negative to positive. So it was, I think, our first realization that this is a much more involved world. And thank God, in the shelter, this is Barbara McGinnis on the left, and after whom we named our thing. And Barbara's a nurse that taught me everything. Yoshiko, who's on the right, was a nurse practitioner who was on my team for many, many years. And you can see these are the old days of before digitalization. And we used to carry those things around. But anyway, Barbara's job was, she was the TB nurse from the state assigned to Pine Street Inn. And that's how we learned much of what was going on. And then to take care of it, we had to learn, where did people go? Because everyone who got sick in the shelter didn't want to come back. They all stayed outside somewhere. So we had to figure out this whole system of how do we find everybody every day. And I learned from the nurses and from the outreach workers, most homeless people have a relatively ritualized daily life. When you take it, step back, it looks like chaos, but each person is ready. And we learned just how to do this. This was the last day, by the way, of the 18th month of serving this man who stayed outside. He was actually from the Comanche Indian tribe and was a character. But what we also learned about village, this is, remember, I didn't know anything about this stuff then. I had no public health background, but I had been a bartender right up until my second year of medical school. And there was a bartender who's at JJ Foley's, this wonderful guy. And I was asking Ed if he could remember his name, but there were 7 of them. And by the way, of the 60 cases, they were all men. No one was immunocompromised. And it was, because it was at the same time AIDS was coming up, but many of them were drinkers. That was it. And 7 of the men used to go to JJ Foley's before they went to the shelter at the end of the day. So the bartender would just give them their medicine before he would pour their beer. And he did the entire treatment, you know, with us checking. Oh, I'm sorry. And I realized this would be illegal today, but that was kind of, that was all we had. And there was also a coffee clutch in South Boston where a man had a barbershop and he had coffee in the morning. And he would do 4 of the men used to get their medicine from there. And we ended up as a village sort of took over. Now I met Paul when this early on in this outbreak, Paul came to Pine Street. He was a student then, although I don't think Paul was ever really a student. But he came down and he was fascinated by what was going on, wanted to figure out what were we doing. And I remember John Bernardo was the other pulmonologist, Ed Nardell was there. And it was kind of a beautiful working of state and city and nurses and doctors. And he was great about it. And, you know, in many ways, I want to say a lot of what we learned and a lot of what he learned was the mutual walking together and all that. This was the MMR. Now, just to step back for a moment, when those people put us together, this is what they demanded. They demanded, and I think of this, if I could put other words in there now, but this was literally what they said: establish a health services delivery system that provides continuity of care from street and shelter to hospital. And we remain the only healthcare for the homeless program in the country that is part of a hospital because of the demand of the people. And they said that because they knew when they got sick, they felt most stigmatized and most frightened when they were in the hospital. And if you talk to any of our patients now, it's the visit you do to the hospital when you take care of them in the hospital that they remember most. Okay. And so I sort of think that's early. I didn't know accompaniment at the time, by the way, but you heard that I did do theology for 2 years at Cambridge, which I don't often talk about, but that was right at the time when Father Gustavo Gutierrez had written his first book on liberation theology. By the way, we should remember him because he died, Steve Reifenberg, he died just a few weeks ago. An unbelievable human being and very devoted to Paul. But anyway, so the other thing we had to do is work in teams. And I want to say that what I've learned from this, I thought it was, wow, this is a cool idea that we're going to work in a multidisciplinary team. But that wasn't it at all. The homeless people were so, they hated, not hated, they were very suspicious of people like me because I was going to come and spend a year. And what they were looking for was a commitment. Okay. And they didn't want to open up to me. And in fact, they said this, they don't want to share everything with me. And then at the end of a year, I'm going to go do my career somewhere else. They didn't want that. And I was horrified. I thought they'd be thrilled that I was doing this. But that's what so they made us work in teams. I've never had my own panel of patients. I've always shared it with a nurse practitioner, PA, now, you know, a recovery coach and a psychiatrist. So and we all share equally in the care of each person. So if any of us leaves, there's still a team that every person knows. Pretty radical idea coming in 1984. And then the last thing they asked us to do was do this respite care thing, which we had no idea. There were none at the time. This is the earliest picture I have of our respite program. It's in the Shattuck shelter. Governor Dukakis gave us 25 beds. And we were just supposed to take care of people coming out of the hospital who had no home to go to, but were way too sick to be wandering the streets or being in the shelters. And we did 24-hour care there. And it was a real experience. The problem, of course, was, you remember, for those of you who trained in my age, if any of you are here, but if you had cardiac surgery at Mass General back in 1985, when I was a senior resident, your average length of stay was 5 weeks, okay? And if you had gallbladder surgery, it was an average of 10 days. And most surgery was of 7 to 10 days in the hospital. Chemotherapy, if you were sick with cancer and needed chemotherapy, it was a week in the hospital when we gave infusion, waited till you were okay to go. And as we've improved that, and hospital lengths of stay have come way down, homeless people have been the unintended bad consequence of all that. They have no place to go. So think of that. You've got cancer, you now have to go radiation and chemotherapy, and you just go in the morning and then you hang outside for the rest of the day. It's horrifying. Anyway, so respite started with, it was kind of easy in the beginning because people stayed in the hospital a long time, until this man came in. And he became a really cherished friend of ours. But he came in and he had been sent out of the hospital. He's got kidney failure. He's on ambulatory peritoneal dialysis. And he has, because of HIV nephropathy. So he was the very first homeless person we knew of in Boston to be diagnosed with AIDS. This is already 1985, so it's frame shifted by 3 or 4 years from what we were seeing in the hospital. And he had no place to go. And so we, at our respite program, started to realize we became more and more of an AIDS and TB unit than we were of anything else. But it reminded me of, and it was mentioned in one of the panels, that, how horrifying it was from sort of when I was an intern in 1982, we saw our first cases at Mass General. And for those next years, everybody who had AIDS died slowly after a year or 2 or 3. And it was just a hopeless feeling. And taking care of him, while it was a real privilege, he just ended up getting every opportunistic infection you can imagine. And he died blind and very thin. And there was little we could do other than to just take care of him. But now I think back, and I'm sorry to just do one bragging thing here, but we now have an HIV team in our program. And you may recognize Jen Brody. She was a doctor at the Brigham who trained with many of you, but she leads our team. And they now, with the protease inhibitors and the new things, we can now take care of people who are out on the street, basically have almost, the same viral suppression that you will see in most clinics, but it requires following people wherever they go. They have to, in fact, the nurses team is called the NAG team, and they have to go nag people. But it's an amazing team. And as I should make this, as Jen Brody and her team always remind us, because I don't know if we get complacent. We try to be apolitical in everything we do because we're trying to keep access, but they're the ones who keep reminding us that we need to be in solidarity with everyone who's being persecuted and killed across the world. So I should, that team would be the first to speak about that. And then in respite program, what we started to learn over many other things, we could have specialty care come. And now this is something I did learn, that you can do a lot of work in the community, but if you're taking care of a very sick population, you need the hospital and you need the specialists and you need to have really ready access to that. So we started to figure out how to do that. This is Ernesto Gonzalez, who is an amazing professor here at Harvard Medical School, just retired a couple of weeks ago. He was the head of ambulatory dermatology, and he would come and the residents still come at least once a month and now even once a week to do derm inside respite. So we can bring people and get all that. I learned, the funny thing about this picture is our staff is all around him, and you'd be amazed how everybody has a rash that they're trying to show Ernesto, because I don't know if you've tried to get to the dermatologist, it takes you a long time. And then the other thing that I would share with you that sort of try to keep into the theme of what have we learned from the people we're trying to take care of, is that death is ubiquitous among homeless people. The mortality rates for people living in the shelters of Boston are 4-fold out of somebody of the same age in the city of Boston, 4-fold. And we don't even know what the exact cause of that is. And if you live on the streets of Boston, which is a rough sleeping population I spend most of my time with, it's 12 times the rate of people living. So those are mortality statistics that look like they come from another world. And anyway, so when people are dying and die, there's a huge pressure on the community of homeless people to make sure you market the passing, because it's frightening. And then where do people go when they die? And I made a mistake the first time I was taking care of somebody, and I spared you this story, but I got him a nursing home bed and a place where he could have really good hospice care and be taken care of. And, and I got him into a nursing home, and 3 days later I came back to the shelter and there he was, and he hated it. because that's not where those weren't the people he knows. He was in a nursing home, didn't know anybody. He told me everybody's looking out the window or watching TV, and I want to die among the people I know. And so finding ways to do good and better end of life care is better. This is our respite program though, where we can do it. 2 men in the same room. One is 82 and dying of a neurological cancer, and the other one's 37, standing up at Byron, and he has lung cancer metastatic to his brain at this point. They're both going to die. But if you look for a second at Tommy, who's in the bed, we met him, if this goes, we met him, I'm sorry, let me see if I can make that happen. I'm having a little trouble, you guys. Can you make that go forward, or is that me? Uh-oh, I don't even know what to do when that happens. I'm so sorry. But in the next picture, you'll see where Tommy lives and works. Oh no, I just went ahead about 5. I'm sorry. So it was doing it all the time. Can you go back? Can you go back a little bit? I'm so sorry. But anyway, with Tommy, we met him out at Suffolk Downs racetrack, where one day a man came into us and said, "Who's supposed to be taking care of homeless people in Boston?" We said, "We're trying to do that. What's going on?" And he said, "Well, there's 400 people working out at Suffolk Downs, our local thoroughbred racetrack, living in the back barns, and they're essentially working all day long." I'm sorry, can you go to, yeah, the one that's number 15. And there are 1,500 thoroughbred horses stabled out there, and in the stables, people have to take care of them, and those are the workers that are paid under the table, have absolutely no rights whatsoever, and they won't come into a clinic because if they leave their job that day, they lose their day's wages, and the pressure on those jobs is intense, so somebody else will take their job. So Tommy worked there from the time he was 14 years old. He was in the racetrack, never left the track, never learned how to read or write, but he knew horses really well. And when he was dying, we finally got to know him enough so he would come to our dental clinic as long as we would go get him. He came to our health clinic. And then when he was sick and dying, he came and would stay at McGinnis House. But if I can get the pictures back up, I'll show you how we, should I keep going or no? Oh, that's it. Thank you so much. I'm sorry. So this is Tommy taking care of horses with a woman who is one of the horse owners. And I could give you the whole, it's a whole culture out there, which is now gone, by the way, because of gambling. But you can see that he just is good and he takes care of him. He knew everything about, oh no, I'm gonna have trouble now, you guys. Can you just advance the slide one at a time? Because it won't work to this, you guys. You can just advance. Can't see him, I'm sorry.
Working on the AV.
Okay. It's funny to be in this spot and have this happen. I'm sorry. Okay. So what I'll keep telling you. So what happened? So Tommy's out there working. We learned that we went out and started doing a clinic at this racetrack, which we had never dreamed about doing. This is 1990, 91. And we actually, our staff loved these people because they were the hardest workers we ever knew. They never came to you didn't come to you with an acre of pain. They came to you like when their arm was broken. So you couldn't help but love them. And they were working. Most of the money they made, by the way, or half of the money they'd send back home, mostly to Central and South America where their families were. Tommy, as he got sicker and sicker, all he wanted to do as he was dying was to get back to the racetrack to say hello to everybody. So this is an example of the stables where people would live. He lived in actually just this side. He lived in one of the tack rooms all his life. But these are the horses, and it's really quite extraordinary out there. But let me see if I can get this. So this is Trish, who is our nurse, and we had to even to do rounds in the morning. You had to go interrupt people while they're working. They would never come to you even to the waiting room. But and for those of you who might be anxious the way I'm, if a stallion is really hyper, you put a goat in the I didn't learn this. You put a goat in the stable, and the goat calms them down. So you'll see goats all over the thing. And this is Trish, our nurse, doing that. And when Tommy was there, what we would do is once a week, put him in the van and bring him to the racetrack so that he could just spend the afternoon there. And this is him maybe a week or two before he was going to die. And when he came in this last picture, if it still came out, as you can see, he just it was his world. He loved it. And we had to learn how do you help somebody die well in that world was the real challenge for us, but he was great. And I'm going to tell you just for another, I don't even know where I am studying time-wise now, I'm sorry, but just to tell you a story that Steve Reifenberg is here somewhere. And Steve, you know this story all too well. Steve Reifenberg I met in Pine Street Inn back in the 1980s before either of us knew what we were doing with our lives, right, Steve? This is Michael, who's a guy I met on the street back in 1986. And I met him, he lived on the street. He had been there for quite a while. And I met him when I was on this van. So Pine Street Inn has a van that is funded by the Department of Public Health in Massachusetts. And it goes out to reach out to the people that are living outside. We have we have an East Coast town where 95% of everybody who's homeless in Boston tonight will be in a shelter, and about 5% or less will be out on the streets. And they're the people that could have a shelter bed or something, but for lots of complicated reasons, they stay outside. And they turn out to be a very, just a very different subsegment of the homeless population. But to get out to them, they were the ones who were dying most frequently. So this was a van set up. I wanted it to be a medical van, but I lost because the homeless people that we were working with wanted soup and sandwiches and blankets. They didn't want a doctor at nighttime. So this brings every night from 9 at night till 5 in the morning. And this is since 1986. These folks go out from 9 till 5, think of that. And they're like they're like the heroes of the story. They're just really, they don't judge anyone. Most of them have lived through all sorts of poverty and homelessness, and they're in recovery from different things, but they just go out and know everyone. And I've been able to ride for, at least for the 35 years after that, I rode 2 nights a week on the van, and that's how you get to know people outside. So I got to know most of the people I take care of by serving coffee and blankets, and then saying, if you need anything, I happen to be a doctor. And it was the best thing that ever happened to me. And this is the coldest night we ever had. This is minus 10 degrees. It's a northeaster. Still about 100 people in Boston sleeping outside, including this man at Copley Square Trinity Church. This is a 92-year-old woman who stayed out all winter. You can see that her legs are now red and really swollen, not yet infected, but we spent the whole winter trying to coax her in. When I think of the challenges of mental health in our system, this is an example of how little we have to offer people. We could take her in, but what do we have to offer after that? It was really tricky. And then this is Michael, the same guy 5 years later, now where he's still outside. I've learned a lot about him by this time because giving coffee, for night after night was kind of fun. And he grew up in the South. He was brutalized in a terrible family situation, removed by the state, sent up to Boston to live with a family up here. And something happened there. And he ended up on the streets when he was 14. He's a severe learning disability, so he never learned to read or write. And he's on the streets, okay? And he has wonderful street smarts, and everybody adores him. And what we ended up doing was we were doing stuff at nighttime and realizing it's nice at night, but there's nothing open. So we had to try to find out if we could get out on the streets during the day. Remember, this is kind of a ridiculous picture, but it turned out to be like this wonderful thing where we could go. That's Eileen in the red hair, who's our psychiatrist, who's from DMH, and a therapist is Kendall, who's there, and then a couple of nurses. And we just go out together and see people. And over time, you get to know just about everybody who's outside, and you don't have to refer anybody anywhere. We're all right there. It's really pretty clever. Part of what the people demanded. Then we learned a lot of things about what you can do on the street if you're willing to go to where people are and bring the expertise. This is Dave Munson, who's really a remarkable doctor who trained at Tufts Medical School and then went to MGH, and he's been with us about 12 years now. This is taking care of a lady who's 82, has heart failure, really bad heart failure, won't go to the hospital until the ambulance brings her in because she can't breathe. But she lets us do all of her heart failure care right there at South Station. As long as we do it there, we can listen to her heart, we can change her medicines, we can weigh her, and we keep in touch with the heart failure clinic at MGH to make sure we're doing all the right things. And that happened for 10 years before she ended up having to go to a nursing home for lots of other reasons. And this is Jim Bonner, who's our full-time psychiatrist, who I want to celebrate because he retired about 4 years ago. But this was, for 10 years, he was our psychiatrist in the street. And he learned that psychiatry at McDonald's is often much better than psychiatry in a thing that says psychiatry. And so he had this kind of renaissance of realizing people that we used to call treatment resistant were not resistant to treatment. They were just resistant to the way we wanted to treat them. But if you treat them that way, and this is someone who he did all his therapy, all his medication, everything. I'm sorry, I said that was McDonald's. This is actually Burger King. And it was just a revelation where you can do so much stuff outside if you're willing to think outside the box. And then things like the public health things, people never got their flu shots and vaccines, but as we got to know people more and more, they would all say, like, this is, we pick a week to do flu shots outside. And this is Jill, who's our physician assistant, giving the shot. And we learned that if the person you know gives you the shot in a place you feel comfortable, they almost never say no, which is really interesting, even though we wouldn't have believed that at first. I have a story behind that with that's Pat Perry, one of our doctors, the guy had said no to Patton, but Jill came up and said, hey, what I remember, hey, John, she knew him well. Can I give you a shot? And he goes, oh, sure. And this is Pat going, are you kidding me? And then just an investment, a return on investment, which we realize is all about what Paul was talking about, this is COVID. This is a Mass General, a little park we call Mousy Park at Mass General, which we could talk to you about. It became like Cheers for homeless people, where everybody knew everybody you could come to. And this is when the COVID vaccines came out. Homeless people, about 40% of all the people living in shelters got COVID. So it was pretty devastating for us, and I could talk about that. But when the vaccines came out, this is Jen, our physician assistant, giving a shot in the park to this guy. And I think we found 2, maybe 3 people that said no to the vaccine. Isn't that amazing? And we realized that, one, the people who are homeless out there knew how sick everybody got. They wanted to protect everybody. But the other thing is they're perfectly willing to say yes to someone they trust who's there with them and gives them the shot. So, as Paul would have said, right, this is exactly what we had to learn. And I'm going through years of learning here. I wish we had learned this quickly. Well, I wanted to show that because Tracy, by the way, did call today and say hello to everybody. He really misses Dee Dee, especially you. He said to say hello to Dee Dee. And he's next door just getting a new knee. So frame shift now, this is now Michael 15 years after we first saw him, and he's stemming outside of Starbucks down on Charles Street and Beacon Hill. It's kind of a ritzy area. He knows everybody, and he's making a lot of money and really doing well. And I'm going to frame shift it here. We brought him over to our clinic. This is now about 5 years ago. He's getting really sick. He knows us now, though. At least he's now able to say, I'm sick, can you help me? And it turns out he's got prostate cancer metastatic to everywhere. And we got him over to the clinic, brought him right up to the clinic at MGH. This is where you realize it's so nice to be able to walk into the specialty clinic and get things done. And I'm going fast. The clinic is great. This reminds me of Paul as well. So we have a everyday clinic at MGH for street folks. These are some of our nurses with one of our patients, but it's where we can have residents and, like here, there's a few patients, there's a resident there. 2 students from Dartmouth, by the way, if Jim's here, that's Zoe Gottlieb, actually, who you would probably know, and Gabriella Emanuel, who have both gone on to do amazing things, and Jess Hoy, who's here. So we were able to our ranks can swell by getting people a chance to see what's going on and work with people. And then this is what our new respite program looks like. And we brought Michael over there, and I can give you the whole story, but I'm going to stop here because I'm worried about time here. But this is Michael and the lesson I learned. So we've known him now for 30 years, okay? And he comes into McGinnis House, and he's never been housed. And I'm worried to death about him. He's just been diagnosed with prostate cancer. We're going to start chemotherapy. It's kind of grim. And I'm going in to give him the grim news. And he's sitting there and he's in bed. He said, what's wrong with you, doc? He sits up and he said, and he's got a bed. He's got 3 meals a day. He's got these 2 nurses hanging over him. And he just goes, it doesn't get any better than this. And I felt like a fraud, it's like, oh my God. Anyway, and the rest of the story, I'll just go really quickly is, so, we got him, he went into remission. We got him over to our step down respite program. And then from there, we were able to get him housed. This is him signing the first ever apartment he had. He's 62 years old. We're trying to bring him to his house, but but he stops to pick up, we had to go to the shelter to pick up a cat because he wants to have a cat. And I don't think this cat wants to be there, by the way, if you look there. But he settles in and he's great. This is him in his apartment. He doesn't have great taste, but he has, and then he starts calling us. This is when we learned the real part of our version of accompaniment. First call I got from him was late at night, and it was saying, Doc, because remember, people get lonely when you put them in their own house. They have no one around. They call up, they said, Doc, you got to help me out. And he couldn't he couldn't figure out how to turn on TV with the clicker. The clicker was too complicated. So I had to go over and show him how to do that. And then like after that, we'd get calls, all of us on the team, like, Doc, it's 8:30, same old place in JP, closes at 9. I need a meatball sub from there before it closes, right? And so we would, ferry food, whatever it was they needed, but we're just trying to keep them in gear. And then this is him, he has a recurrence and it gets really bad and there's nothing we can do. This is now 2 years ago right now. And that's Becky, our nurse. We would have to pick him up and bring him for his chemotherapy and bring him home. And then it gets really bad. Now he's dying and he can't, he's got bone pain like you can't believe, but I can't get him to come from out of the house because of the cat. Right, he will not leave his cat alone. He wants to take care of that cat. So Jen Nunes, that same PA that was doing the shots, was with me on this home visit, and she said, "Oh, Michael, I'll take the cat." And so she took the cat, and then he came to the hospital with us, and then came to the hospital. And this is the last picture I have, and this is the day before he died. Calls up as I'm going to the hospital and says, "I need a Big Mac." And he's dying. I'm worried about this guy. He need a Big Mac. And he said, "But I can't have no lettuce, Doc. I can't have any lettuce." And what I remembered from that was if you go to, it's hard to get a Big Mac with no lettuce. It takes time, okay? And so I brought it into him and I thought, he's an extremist. He's in terrible pain, but he's on lots of medicine now. And when I said, "Mike, you sure you want this sandwich?" He sits up. This is the day before this man dies, right? Sits up and he smiles, this huge smile. And he can't eat the sandwich, but he can smell it and he can do it. And it was like, how do you get joy out of every moment in life, right? And this is a man who got given nothing in this world. He couldn't read or write. I mean, he's just been brutalized the whole time. But he ended up dying a few days later, and there was a huge funeral at Beacon Hill at one of the churches for all the people that had affected his life. I could go on, but I'm gonna stop here because I wanted to say, just in ending, that I think, I too thought I was Paul's best friend, so I'm not gonna go in there. But it was such a joy having someone of Paul's stature and Paul's vision while we're struggling inside this world. Paul, the last time I was with Paul to give a talk, we were on a panel, and he stood up, and this was over at the medical school, and he stood up and he wanted to introduce me, and he said, "I want to introduce you to this poor doctor who's just never gotten more than a mile from medical school." And then he talked about Rwanda, he talked about Russia, he talked about everything. But then he would come back and do just what you would expect. He came back and he said, "Now I want you to pay it." And these are students, I'm trying to get them involved in this kind of care. He said, "But remember, they're seeing the same health disparities a mile from right here as we see in Haiti and other places." So he was a person that for me magically turned it used to be a divide between international care and kind of local care. And to think of it as global care, which is what all of you have been doing so magnificently, makes us all feel part of it all. So thank you for this opportunity. I'm sorry about this, okay?
Please welcome to the podium, Dr. Sheila Davis.
Thanks so much, Jim. That was amazing to hear the stories and the impact that Paul certainly had on you and you have had on so many of us. It's wonderful to be with you all today on this special day. I'm Sheila Davis, the CEO of Partners in Health, and I'm privileged to represent a team of about 18,000 people around the world of Partners in Health. This has been a truly remarkable afternoon with rich conversation about Paul's legacy, applications of accompaniment in its many forms. We heard about the accompaniment of patients, clinicians, medical residents, government partners, institutions, the global health landscape. We learned about accompanying students, researchers, general audience, and across academia, laboratories, and beyond. And we've seen how accompaniment has made an impact in the lives of many experiencing homelessness right here in Boston. Accompaniment at PIH, Paul described as the cornerstone of what we do, and the efforts serve as a strong foundation for our big theory of change. Care is the foundation of what we do, and PIH has long said, patients are our bosses. We accompany those patients with a preferential focus on the most marginalized in accessing comprehensive health care, food, jobs, education, and all forms of social support. The same patients and communities from Malawi to Navajo Nation accompany us as the work we do in partnership to create a healthier world. As Paul put it, the distinction between us and those we serve is intentionally blurred. We mentor and train and learn from local staff, hiring more than 11,000 community health workers around our network who offer truly the expertise and leadership in accompanying their neighbors in accessing healthcare. We also prioritize accompanying the next generation of global health clinicians and leaders, from investing in ongoing staff and training to residency, fellowship, and many specialized programs. Paul said that research and training in global health are for naught if they fail to improve the delivery of health services, or if we fail to train and learn from our peers and our partners. We also influence with evidence. We accompany partners in advocating for national and global health policies that prioritize the most vulnerable. We partner with leading institutions, many of those who are represented today, to drive research agendas that contribute to the global health evidence base, informing global health delivery to produce better outcomes in communities that have been historically excluded from high quality and innovative healthcare. Replication. We work in close partnership with national governments and global and regional policymakers to share best practices on proven and replicable models. For example, the PIHUS's work to advance Community Health Worker Access Act would improve our ability to pay for community health workers in the US. And this is a big target of our advocacy domestically and globally. And also the advocacy in supporting the NTB Act of 2023 has passed the US Senate, and we're going to fight no matter what to have it passed in the House. Across global PIH community, as well through partnership and their accompaniment as the cornerstone, Paul has really united and provided this thread connecting us all. He gave us the unifying language for us to use. Many of us felt in our hearts but didn't have the language for. He shared the knowledge and the robust history of liberation theology and the vision to change the paradigms of charity. As many of us do, I'm sure, I was scrolling through my WhatsApps of chats with Paul, and I had many because, as we all know, Paul changed his number many times for the reason that was talked about of giving his phones away throughout the world. It was a beautiful, sad, and inspirational and challenging journey through WhatsApp of messages filled with funny anecdotes, how proud he was of the UGHE students and proud he was of the staff everywhere, and heartbreaking stories of patients who came too late for care. There were personal messages to me as I was losing my father, and Paul and many other PIH friends made the trek to rural Maine to be at his funeral and the luncheon after. He was so happy about the egg salad and tuna salad, finger sandwiches and potato chips, and not the fancy food that he said he often had to have, and said he felt right at home, and he was. Paul accompanied me as I moved into the role of CEO position, and he was excited about the vision of starting the Leadership Council. And he knew and said he would always wanted to be an honorary member. The Leadership Council is meeting this week here in Boston with our phenomenal executive directors from all around the world. And I know he's in the room with us as we talk about the challenges ahead. In the course of walking beside Paul, he showed me what can be accomplished through compassion, dedication, accompaniment paired with expert mercy. I encourage all of us to think about what we will do individually and collectively to carry forth and forward accompaniments in our lives and our work. How can we continue to be inspired by Paul's life and teaching and each other's actions, including many of those in the room today? Paul said that accompaniment is both an objective that is set at the beginning of a task and a mode of follow through. So a call to action is to use this concept as a way to orient ourselves, to set a course towards the goal of equity, but also as the means to get there. We know that accompaniment is an open-ended journey, and to embody accompaniment in our work and lives is not simply to check a box. It's the action of recommitting every day to equity and to each other. After all, Paul wisely pointed out, everyone needs accompaniment. Even the accompagnateurs need accompaniment. And as we close this symposium, my hope is that we continue to offer each other this accompaniment and those that we seek to uplift and serve. On behalf of Partners in Health, I want to thank our amazing partners in the Global Health Delivery Partnership, Harvard Medical School, Brigham and Women's Hospital, and the many other partners in the room for the long-standing accompaniment, along with the Global Health Institute, Harvard Global Health Institute, and also want to extend our thanks to all of you in attendance today and online. A special thanks to the event steering committee, as well as the cross-site partnership event team. Pulling something like this together is not easy. And the way that this group worked together, representing many different organizations, is truly extraordinary. It's now my pleasure to invite those who are here in the room today to join us for a reception in the lobby. And thank you again for being with us today and accompanying us and each other through all aspects of our journey. Thank you.